Tell me when we're live. All right, thank you. Good afternoon. I hope everyone is well. Welcome to the bill hearings to the House Health and Government Operations Committee. I'm your chairman, Jocelyn Peña-Melnick, joined by my vice chair to my left, the amazing Bonnie Collison. I want to take a minute to thank my committee for being on time. If you see some empty seats, there's no disrespect meant. Is that some of my committee members have other bill hearings in other committees, but they will come. They have access to this recording and they will watch it. We also read everything you submit and we will read it. There's also some of my members that are not feeling well, and trust me when I say you don't want their bugs, okay? So I'm going to go through some rules just to make life easier. I kindly ask for your patience if we encounter any technical or streaming issues, which we will. It happens, right? Please set your electronic devices to vibrate, which I'm going to do right now because you don't want to be embarrassed unless you have some good music there. Mine will probably have some merengue or salsa. As a reminder, there's no food or drink allowed in the gallery, and that's because our staff doesn't have the time to clean up. They have a lot of work, and I want to take a minute to thank our staff, those that are here and those that are listening, for keeping our life together in HGO as well. You will see that we will drink, and it's because we sit here for hours, right? And we need to stay hydrated. I'm going to go through the rules of bill testimony. For each bill that we have, and we have today 1, 2, 3, 4, 5, 6, 7, 8 bill hearings, we are going to hear first from the bill sponsor and then the sponsor panel. In this committee, I have decided not to time the sponsor. So you could tell your story, but don't abuse it. Don't let me stop you, okay? Then the sponsor panel, you have 2 minutes to present your testimony, and it's going to be in the following order: favorable, favorable with amendment, and unfavorable. And then we are also allow virtual witnesses to testify, right? Because we should make things easier for people. And it's favorable, favorable with amendment, and unfavorable. If there are a large number of witnesses, I will alternate between favorable and unfavorable. Why? Because I want to be fair, right? To give people a fair chance of being heard. A timer is displayed on the screen and the witness panel, and you will actually, you will hear the sound when your time has expired. Look, I'm not going to interrupt you there and then, but I do ask you to give me some grace. Don't make me have to tell you to wrap up, and just as soon as you hear that, wrap it up, okay? Please adhere to our wonderful committee of the usual committee rules of 1 question and 1 answer. And please keep your question brief. Remember that you can get in touch with these witnesses when we're done, right? And remember that we do everything here, and I'm looking at my friend over there from Howard. We do everything here. You know I love you, Terry. We do everything here in subcommittee, and we really get into it, right? We dissect things here. We allow everyone to come here to subcommittee. Members of the public will be able to view us right now, live stream on the Maryland General Assembly website and on YouTube. And today we have the bill hearings in the following order. But I want you to remember that I have the discretion, humbly, of changing it if someone is running late, right? If a witness is not here. So do not get upset with me if I have to change the order. But this is how it's going to go for now at 1:07 p.m. House Bill 424. Followed by House Bill 417, then House Bill 565, House Bill 666, House Bill 665, 459, 429, and I'm sorry, Delegate Kipke, but it may change. The last bill of the day will be House Bill 418. House Bill 424 is Delegate Collison and Delegate White Holland, and it is the Prescription Drug Affordability Board, Authority for Upper Payment Limits, Lowering Prescription Drug Costs for All Marylanders Now Act. Will you be so kind and bring your panel, please? And when I call the bills, will you please bring your panel? And if you have to add more chairs, do so. Whenever you're ready.
Yeah, come on. And Michelle's virtual, okay. Yeah. Good afternoon, Madam Chair.
Good afternoon.
Members of the committee. All right, I'm going to start by begging your indulgence. I'm already planning your meal.
If you have a bill that is very long and have many witnesses, and we have to work long hours, you have to pay for our next meal.
My written testimony, which you have in your folder, is literally a treatise about everything that's going on in pharmaceutical pricing, and I ask you to read it. My oral testimony today, I'm going to try to hit the highlights of that, but even that's pretty long. So I'm going to be honest and speak from the heart right now. Our healthcare system is not just broken, it's really failing us. Despite spending more money on healthcare than any other developed country, we're left with outcomes that pale in comparison to those other countries. Instead of a system that uplifts and protects our people, we have one that profits off the backs of our people, leaving the most vulnerable among us, our elderly, our sick, our struggling, desperately fending for themselves. Prescription drugs, a cornerstone of modern medicine, have become a symbol of that failure. They account, we just heard this the other day, for about 40% of the premium dollar, and 10 years ago, that was less than 30%. Year after year, those prices climb many times more than the rate of inflation. Polling data tells a sobering story. 1 in 3 Marylanders have skipped a dose, rationed medication, or left a prescription at the counter because the cost was too high. So we've heard about the cost of drugs in other countries before, but I decided to do a little bit of investigation, and I commissioned my intern, Nathan Chabat, to do that, and he did an amazing job. I asked him to go through the pricing chain in Germany. How does drug pricing work in Germany, whose healthcare system is strong? We found in that investigation that the infrastructure for that process is very much like our Prescription Drug Affordability Board. In that system, the federal government is the oversight body, which is analogous to our state, and then they have a process by which 2 independent bodies, one which includes practitioners, customers, hospitals, all the people that are represented on our stakeholder county and our board, that's one group, and the other group is of medical experts who look at the efficacy of every drug that is being brought into their country. So the result of the negotiation over these 2 groups and what they find is the basis for the negotiation with the drug company. We were able to find the difference of 2 drugs. You know, we hear this all the time, but this is the data. Skyrizi is one of those drugs that we were able to find. In America, a single dose of Skyrizi, the wholesale acquisition cost is $21,017. $21,017. In Germany, it's $3,711. Dupixent, it's a very popular drug. The wholesale acquisition cost here in America is $3,993. In Germany, it's $1,123. So the German healthcare system isn't like ours. I'm going to say that out front. But these are the same drugs being made by the same companies that we're using here in America. So what I'm hoping is that you can see the possibilities here. By empowering the Prescription Drug Affordability Board to establish statewide upper payment limits in the commercial market, not just the state and local government market, we can take a critical step towards reversing the trend. The board is focused right now on its momentum to set those upper payment limits for 2 drugs, or excuse me, that's not fair. to look at the possibility of setting an upper payment limit on two drugs, Jardiance and Farxiga, which treat diabetes and heart disease. These medications represent the single biggest cost for state employee health plan. Now, here's a number I need you to think about. Between 2020 and 2024, 4 years, the price of these drugs to the state went from $14.5 million to $29.3 million. It almost doubled in 4 years. The burden on state budgets and taxpayers have already contributed $870 million to the development of these two drugs through research grants. And still, the prices here in America are almost 10 times more than they are in Germany. The board has already begun its work on a transformational change in how we look at drug pricing here in Maryland. And much of the effort to establish the process for cost reviews and determination will translate seamlessly into a statewide upper payment limit mechanism. The board is fully equipped to operate with this expanded scope of authority, taking a comprehensive approach to assessing drug prices. Such mechanisms are not only logical, but essential in a state facing significant budgetary pressures and uncertain federal policies. So I was hoping, last year during this hearing, we went on for a little while with questions. So I'm hoping to anticipate some of your questions and what you will hear from the folks who are going to come after us. You're going to hear that the savings to insurance carriers, because if insurance carriers are paying less for drugs, the supposition is those savings will be passed to the consumer. There are those who are skeptical about that. But I'm going to have to remind you, premium rates are regulated by the Maryland Insurance Administration that take into consideration all of the factors of what happened in that company over the previous year. They are also, insurance carriers are also mandated by law under the ACA to spend no more than 20% of their income on administration. 80% has to be on actual services. Pharmaceutical companies are not regulated in any way except for their product. Their product is regulated. Their pricing is not. And it was supposed to be managed by competition. But given those figures I just gave you, I don't think competition is working on behalf of the people who need the drugs. Our new insurance commissioner has submitted a letter of support for this bill in your packet. She is out of town this week. She would have liked to have been here, but can't be here. You're going to hear the real problem is pharmacy benefit managers. I am not even going to try to justify the practices of pharmacy benefit managers. And I agree, they are a part of the problem. But it's all part of that chain where the drug the price is set by the manufacturer, and then there's negotiation among the PBMs. And they are both major factors. You will hear that we will disincentivize innovation. I'm not really sure why that works or why we think that, because they're still going to be selling their product at a profit. We are not taking away their profit. So why are we disincentivizing the innovation? You're going to hear that companies will refuse to sell their products in Maryland. This has not been the experience in any other developed country, and Maryland is not an insignificant market. Our state is further protected by consumer protection provisions of the Maryland Commercial Law Code, which says you can't advertise in Maryland if you do not intend to sell in Maryland. That would be the elimination of a fairly significant media market. You're going to hear the U.S. prices are subsidizing research and development. Between 2017 and 2021, the National Institutes of Health contributed over $134 billion to biomedical research, funding every single new prescription drug that came onto the market between 2010 and 2020. The American public is paying twice for the drugs, once through taxes and again through the inflated drug prices. I would suggest to you that any financial loss they could experience as the result of some upper payment limits on some of the most expensive drugs could simply be made up by not marketing the products to the general public, and instead marketing them to the medical professionals who will know, who have the expertise to prescribe them correctly. There is also a $370 million a year spend on lobbying. That could be repurposed as well. But when you think about the advertisements when you're watching the Super Bowl, and if you see the people dancing to a tune around a fountain selling a drug, that spot costs $7 million. You will hear a concern that drugs for rare diseases could become unavailable because of their high costs. I am confident, because of the iterative process of feedback and decision-making between the board and the stakeholder groups and the public, that this will not happen. The Colorado board, it did happen in Colorado, and the Colorado board does not have that iterative process that we do. And it set its first upper payment limit on a drug that treated cystic fibrosis. Not cool. They had to rescind that. Our board has learned from that. The board hasn't accomplished much in 5 years, so how can we trust it to do it now? So the board was created in 2019, and the members of the board were identified in that year before COVID, 5 people with knowledge and experience in health economics and the pharmaceutical pricing chain. In 2020, the funding for the board was vetoed by the governor. So we had to wait until 2021 to get the funding. The previous governor did not appoint his appointees to the stakeholder group until fall of '22. So we were held up another year by that. The creation of the board is an example of innovation, and we want to get it right. We want to make sure that the decision-making processes are rigorous, comprehensive, and that they are strong enough to stand up against any legal challenges, and they are ready to go now. So why now? The stakes could not be higher. With uncertain federal protections and no end to rising prices, it's time for Maryland to act decisively. We did change the bill a little, and that was to include a contingency plan to say that it would not go into the upper payment limit consideration would not go into place until we had been successful in implementing for the state and local governments. But we want to be ready to go as soon as that happens. I need to be clear. The board's mission is not to restrict profits, but rather to ensure that the basic health needs of Marylanders are met without necessary financial hardship. The board is able to carefully monitor economic situations and adjust practices based on the changing market conditions, ensuring that it can protect consumers without dismantling the industry. The fiscal note, which we just saw about an hour and a half ago, references the hiring of an assistant attorney general, which may need to happen in this setting. However, the board is funded through an assessment on all of the healthcare entities that come into Maryland. It's a tiny little piece, like everybody pays like $1,000. And so any new staff for the board would come out of would come out of their funds. And we're here with Dr. York, if he can correct me if I'm wrong. So too many of our families, our neighbors, have been faced with the impossible decision of choosing between medication they need and economic stability. Community resources and leaders have indicated this remains a top issue for their members. Groups like NAACP, AARP, AFSCME, 1119 SEIU, the Legislative Black Caucus, and 450 members of the Health Care for All Coalition have all spoken to the importance of addressing high-cost drugs. And they're asking us to do more.
Hey, Mark. Hey, Mark. Hey, how are you?
You need good music, remember?
I apologize.
Said that if you have a phone that you didn't put on vibrate, it has to have salsa or merengue.
Right, exactly.
All right, go ahead.
So I think it's time to do more for our folks in Maryland. It's time to be ready to go as soon as we have everything in place with upper payment limits. And I respectfully urge a favorable report on House Bill 424. Let's prove that we put people over profits, that we put people first, and that Maryland leaves no one behind. I'm going to turn it over to my co-sponsor, Delegate White Holland.
Thank you so much, Madam Vice Chair. And good afternoon, Madam Chair, and to this esteemed body of the House Health and Government Operations Committee. Thank you for the opportunity to present HB 424 alongside my partner in this effort, Madam Vice Chair Cullison. So as you have heard, again, we're seeing the skyrocketing costs of prescription drugs that, again, as we've heard, that are leaving many of our constituents, many of our communities making difficult decisions to walk away from pharmacy counters, skipping doses, rationing doses, and even finding themselves having to make difficult choices when it comes to choosing between essential medications and necessities like rent, utilities, groceries, et cetera. And so when I put on my public health hat and my legislative hat, it's very clear and apparent that there are persistent socioeconomic and racial inequities which have translated to poor health outcomes. And we also see that Black and Latino adults older than 65 are between 1.5 and 2 times more likely to report difficulty affording their medications than their white counterparts. And so within the first month of this new year, we have seen pharmaceutical companies hike the price of 575 drug products, often above the rate of inflation. Among them were drugs to treat conditions that disproportionately affect Black patients, like diabetes, HIV, and certain cancers. As you've heard, Marylanders cannot wait. And for communities of color, especially in the Black community, we cannot afford to wait, which is why the Legislative Black Caucus of Maryland, the nation's largest legislative Black caucus, is pleased to stand firm and to stand confidently in their support of HB 424. To help alleviate these rising costs, HB 424 is a tool that would expand the first-in-the-nation Prescription Drug Affordability Board's authority to set upper payment limits on drugs for all Marylanders. As you've heard a few weeks ago by our Executive Director, York, the board is thoughtful, is transparent, and has outlined a comprehensive process to establish upper payment limits for state and local government plans. Paired with a thorough stakeholder feedback process, this positions the board to have representation on its 26-member stakeholder council that includes patients, providers, manufacturers, researchers, pharmacists, PBMs, employers, biotech companies, pharmacologists, carriers, essentially all those who represent the entire ecosystem of prescription drugs are at the table. Their input, paired with public feedback, along the way informs the work of the board, ensuring its members consider the intended and unintended consequences across the entire supply chain. More importantly, as this committee learned, There are both upper payment limit and non-upper payment limit opportunities that can certainly be explored. In fact, Executive Director York extended an invitation to all of us to utilize the board as a resource as non-UPL policy recommendations are considered. This board has options, but now is the time to add another tool in our state's toolbox to address skyrocketing drug costs with expanded authority. Again, as Vice Chair Cullison mentioned, you will hear and see arguments against this legislation as it would hinder innovation and research development. And so to counter that, I encourage you to refresh your mind and your memory on the report that is in the witness testimony and in your bill file that references the Public Citizen Report that will provide you with a breakdown of how many of these pharmaceutical manufacturers spend considerably more on advertising and self-enriching activities in comparison to research and development. In addition, you will hear opposition indicating that we simply don't have enough data and await an outstanding board report that is due to this committee on or before December 1st of 2026. This report is set to outline the legality, obstacles, and benefits of setting statewide upper payment limits. More importantly, we know a lot more now than we did back in 2019. As you've heard, back in 2019, this was a novel idea. This was a new idea. And since then, we have seen other states like Colorado, Oregon, Washington to establish their own boards and have witnessed efforts at the federal level through the Inflation Reduction Act that offers us a useful framework for how rate setting could be completed, paired with the board's current focus on state and local government plans in setting upper payment limits. And even if we had all the data, I am not confident that it would be enough to alter the opinion of the opposition who believe that PDABs do not work, despite other industrialized nations, as Vice Chair Cullison uplifted with Germany's example, with these drugs in their markets having similar mechanisms in establishing upper payment limits. And so let's give our board all the tools possible to address these rising costs amongst drugs that impact significant portions of the population and work collaboratively to advance other non-UPL policy recommendations. So colleagues, Marylanders cannot wait any longer. I urge and respectfully ask for a favorable report. Thank you for your consideration.
Testimony, who will be next?
Ms. Miller.
Good afternoon.
Good afternoon, everyone. Thank you, Madam Chair, for allowing me to share my story today. My name is Erica Miller, and I am a resident of Baltimore City. And I want to start by saying drugs do not work if people cannot afford them. And I lost my job because I couldn't afford a drug that allowed me to function at my job. Several years ago, I was diagnosed with adult ADHD. Prior to my diagnosis, I struggled with a busy brain. That's what I refer to it as. Working with my therapist, he prescribed me Vyvanse. I remember when we got my diagnosis or the dosage right, it was then that I experienced what my neurotypical peers call a quiet brain. During the early years that I was taking Vyvanse, I was covered under insurance, but I still faced the high cost of prescription coverage. I went through an unexpected life event. I had a divorce after 13 years of marriage. As a result, I lost coverage, and then I found myself in the position of having to care for my kids, as well as now I am fully responsible for taking care of the cost of what is Vyvanse, which is an extremely high drug without provider coverage. And this is a prescription drug that I need to help me function and thrive in my professional career. I eventually obtained coverage, but the cost was still high. Now functioning as a divorced mother of two, I had to make family benefiting decisions. Part of making those family benefiting decisions resulted in me having to switch to a less performing prescription drug. Let me repeat, prescription drugs do not work if people cannot afford them. During this transition time of trying to find a drug that worked, the executive functioning skills that Vyvanse treated rapidly declined. And I'm almost certain that that is what contributed to me losing my job. I sit before you, still unemployed, but yet confident. I know that my story resonates with many. I represent many Marylanders who are either in or facing a similar situation, and I cannot stress enough that prescription drugs do not work if people cannot afford them. Thank you.
I want to thank you on behalf of the committee for sharing your story today. And I want you to know that we appreciate it, okay?
Madam Chair,
Wish you well, yes.
Michelle Eberly of the Maryland Health Benefit Exchange is virtual. Could we have her now?
Yes, will you be so kind and please bring her up? Thank you.
Thank you.
Just give us a few seconds. And for those of you that are waiting, I thank you in advance for your patience. Hi, Michelle, how are you? Can you hear me?
I can hear you.
All right. You can get started.
Very good, thank you.
It's a little low. Are you able to put the volume up and get closer?
Is that better?
Oh, yes.
Yes.
Okay, good, very good, thank you. Good afternoon, Chair Pena-Melnick, Vice Chair Cullison, and members of the committee. For the record, I am Michelle Eberly, the Executive Director for the Maryland Health Benefit Exchange, and I'm here today to speak to the impact of the cost of prescription drugs on premiums for private pay health plans. I have submitted a letter of support, so I will just recap some highlights here. MHB recognizes the importance of statewide efforts to address the high cost of prescription drug products. Our analysis indicates significant overlap between the top drugs by spending in the individual market and the 8 high-cost prescription drug products initially identified by PDAB to consider for cost review. In 2022, these 8 drugs alone accounted for nearly $76 million in spending, equating to 5% of spending on all services in the individual market. Lower prices for high-cost prescription drugs would put downward pressure on the average monthly premiums. In 2025, the carrier rate filing for prescription, or in the 2025 carrier rate filing, prescription drug costs accounted for 25% of the PMPM rate experience for the most selected plan on the exchange, which was an HMO plan. Although in our value plans, we try to keep drug copays low, the high cost of prescription drugs impacts the individual market premiums. Lowering prescription drug costs may also decrease costs associated with the reinsurance program by reducing the number of individuals whose annual costs exceed the threshold at which we make payments, or for those individuals who do reach that threshold, reducing the claim costs for the program. For these reasons, we support House Bill 424 and ask for a favorable report.
Thank you.
Excellent, Michelle. Let's see if Mr. DeMarco can follow that.
I'm going to go with
Oh, who
Mr.
is it?
York.
Okay.
Dr. York.
Let's see if you can follow that.
Madam Chair, I think I'll be able to beat that in timing.
It's okay.
Madam Chair, members of the committee, thank you very much for the opportunity to speak to you today. For the record, my name is Andrew York, and I'm the Executive Director of the Maryland Prescription Drug Affordability Board. I just briefly wanted to summarize the work that we are doing and provide an update to the update that we provided to you earlier in this session. So just as a reminder, we're currently in the process of conducting our cost review study process on 6 drugs that were selected by the board. If, as part of that process, the board makes a preliminary determination that any of these drugs cause an affordability challenge, then the board can begin their policy review process that identifies the policies that can make those drugs more affordable. One of those policies could be setting upper payment limits for state and local government. The regulations for creating that policy review process are currently open for public comment until February 10th, after which the board can publish final regulations based on the comments that we receive. We expect to complete the process for these 6 drugs, hopefully by the end of this year. HB 424 would require us to make updates and updates to our regulations and processes, but largely builds on the work that we're already doing. If we're able to first successfully complete the process for state and local government as required by the law, then there's no reason to believe that we could not do that for the full state as well. Again, thank you for your interest and support of our work, and I'm available to answer any questions that the committee may have. Thank you.
Wow, you had 40 seconds left. You did it. All right, Mr. DeMarco, come on, let's see what you can do.
Thank you, Madam Chair, members of the committee. I'm Vinny DeMarco for the Maryland Healthcare for All Coalition. Over 450 faith, community, labor, business, and healthcare groups strongly urging you to pass House Bill 424, so ably crafted by Vice Chair Bonnie Cullison and Delegate Jen White-Holland, to give the landmark Prescription Drug Affordability Board the authority to help all Marylanders. As you know from listening to your constituents, drugs don't work if people can't afford them. That's why in 2019, led by you, Madam Chair, and this committee, the Maryland General Assembly created the first in the nation Prescription Drug Affordability Board. You authorized it to make high-cost drugs more affordable for state and local governments, planning to come back in 2023 and expand their authority to everybody if it was appropriate. Unfortunately, as Delegate Bonnie Cullison recounted, Governor Hogan vetoed the funding for that law, and that delayed things. But as you heard from Executive Director Andy York, that board is now poised to make high-cost drugs more affordable for state and local governments, which will save state and local governments millions of dollars, which is great for all of us taxpayers. But that will not help the Marylander who gets a prescription for a life-saving drug and goes to the pharmacy and has to leave it on the counter. Or if they scrape together the money to afford that drug, they have to give up kids' education, utilities pay, rent, other essential need. And it doesn't help all of us who see our prescription, our health insurance premiums bloated by the high costs of prescription drugs. So for all of us, please pass House Bill 424. Thank you.
All right, so this is where I am going to open it up for questions now. For the unfavorable panel, I am going to be fair. When they're done, I'm going to call an unfavorable panel so that we can have both perspectives, okay? And then we'll go back, okay? We're going to alternate. So we're going to start. I did see Morgan first, and then Hutchinson. And Kaiser? Delegate Kaiser, but let's go with Matt Morgan.
Oh, thank you, Madam Chair. Thank you for presenting the bill. I did have some questions as far as the testimony goes. As we know, drug pricing is a complicated issue with some of the rebate schemas and the amount of subsidies that flow in the market. I looked up did some research on your testimony as your panel was going there. There were some comparisons with Germany and us, and that might be a subsidy thing because the example Skyrizi, which is a very expensive drug, it's like $22,000. But if you're on Medicaid, it's $8. So it might be some of the the subsidies. But I wanted to make the point, we heard a lot of testimony here about whether the board is ready or not. Colorado implemented their board in '21, and they have yet to lower a single drug. Now, to be fair, they came out and have recently said that
Delegate Morgan, is there a question in there?
Yeah, 3 drugs they were going to lower. So my question is, or they identified 3 drugs that were exorbitantly cost, and they were going to study lowering. I'm sure that'll trigger some lawsuits. My question is for the board, how can you ensure if you eliminate the profit motive by setting an upper pay limit, how can you ensure that new drugs will flow into the market and actually get approved?
So, as I said, we are not eliminating their profit. They're still making a profit in Germany, and those prices in Germany are not subsidized. That's what the country of Germany is paying for those drugs. For that same dose that we're paying $21,000, that the United States is paying $21,000 for, they're paying, I think it was $5,000 or close to $5,000. So, but The reason they can do that is because they have gone through a process by which they've analyzed what the price of the drug is and how it fits into their overall health system. And the companies continue to sell drugs in Germany, even those that are priced lower, because there might be 3 drugs that do the same thing. And in those cases, those 3 drugs are priced at a lower price than a drug where there's one or only one that does that, or 2 that does that. So they're not subsidized at all. And that $8 for Medicaid, that's copay. That's not what the state is paying. The state is paying $22 for that dose of, $22,000 for that dose of Skyrizi. Someone on Medicaid who goes to the pharmacy, they're paying $8. We have to be careful about where we are in the chain when we're looking at what the prices are. So I think that answers your question. Okay.
I'm going to be fair because I never look to the right. I start on the left first. So Delegate Kipke, you go next.
Thank you, Madam.
You're welcome.
You're lovely.
I'll make it up to you.
I'd ask this question of Dr. Vinnie, but
You always promote me.
but I'd rather put the doctorate to work on this one. So, Dr. York, when I asked ChatGPT, what are the consequences of government price controls, it tells me that it can lead to several negative consequences, including shortages, rationing, decreased product quality, reduced investment, misallocation of resources, black markets, and overall welfare losses, ... Most economists consider price controls to be a problematic intervention in the markets. So, I mean, I've had that concern since the inception of this concept, that, for example, when there's shortages of certain products, for whatever reason, Maryland would be disadvantaged in the market because of price controls, government price controls. Now, I know you are a fair and balanced person, and you must consider this in your the board must consider this in their deliberations. So can you tell me about your thoughts as it relates to my concerns?
Sure. I appreciate the reading of the answer from ChatGPT.
That's our first in this committee.
Hopefully not the last. I think that's coming more and more.
AI.
So just a couple initial responses. So I would say that the board, just through their deliberations, has mentioned that their default is market competition. We want market competition to work in this space. And you do see it working successfully in a lot of cases. Often you can look to the generic drug market, for example. With name brand drugs, they're basically given a government granted monopoly. So it's monopoly pricing that they are basically using there, government granted monopoly pricing. And then when you do have drugs that come to market in a comparable space where you think there would be market competition, instead of what happens of both prices going down, oddly enough, both prices often go up. So I would just say that often what the board is looking at, the first thing we need to do is look at the drivers of the affordability challenge, and what it'll often be is some sort of market failure. And I would also just say that the upper payment limits are a tool in the toolbox. It's not necessarily going to be every case where an upper payment limit is an appropriate tool. I think the first thing the board would want to do is see if there's anything we can do to promote market competition and leave that as a tool when there's kind of a market failure and monopoly pricing. So.
And then just real quick, it was suggested that the MIA has authority over insurance premiums. That was testified to. Mm-hmm. Would you agree with me that that's not accurate with ERISA products, which is 80% of the market?
Right, correct. They do not regulate the premiums of ERISA products.
Okay, thank you.
And I usually wait at the end, but let me do a follow-up. Why is that? Why don't we regulate ERISA products?
I can take that. ERISA is a federal law that governs self-funded plans. So it's they're basically regulated, and the rules are set at the federal level versus the state level. So the state regulates the state market. So it's a different part of the market.
Just for those that are at home. Thank you.
Yeah.
So we have, thank you, Delegate Kipke. You're welcome. I have Delegate Kaiser.
Thank
Thank you, Madam Chair. My question to the Vice Chair, I appreciated all the points you made regarding the delays in the board and how people who said it's been around a long time and it hasn't really. So I appreciate hearing that, but I'm still trying to understand the evidence of lowering the costs. And I know it's hard to see that in Maryland because of the short time period. It's hard necessarily to see that in Colorado. And I'm just trying to understand, because I agree there's the problem. That said, yes. I'm just trying to understand this solution as the best solution or the best part of a larger solution.
Thank you for the question, Delegate, and I am open to solutions, but the reason that we chose this one is, and I need to be really clear, I know you've heard me say this, I think I say this in my sleep every night, upper payment limits are not price caps. It is as if we are going to, the state is going to market and saying, this is what I can pay. I have this much money to pay for this drug. This is all I got, because I got budgets, I've got, other things I need to do with that. This is what I can pay for your drug. And the way it's determined, in this case, that's how much we can pay, is through analyzing all of the data. If you think about, once a drug is developed, there's not a lot of research and development going on with that drug anymore. So why would the price of that drug go up? Why would Jardiance and Farxiga go up over 100% in 4 years when they're completely cooked, as you would say? So the idea is, if we can, on those really high cost drugs, we can say, this is what our budget is for this drug. And the company can agree to not take it, in which case, we could potentially face what Delegate Kipke is alarmed about. But I would say the original bill that determined that created the board said the board could adjust based on accessibility and availability. So we're just trying to say those really high-priced drugs, get those prices down so we could see some of that back in our state budget.
Do you have a follow-up?
Thank you, Madam Chair.
You're welcome.
I think you were giving more of the argument of the theory of why, and I guess I'm trying to see any evidence in practice here or anywhere else of how it works.
So the practice is, as I said, there are developed countries, particularly in Europe, where they're buying our drugs at much lower costs. But one example of what happens when you have policy that makes changes is insulin. Insulin started out being like, and I'm gonna, these are like close numbers, but they're not exact numbers. It started out being like $10 a vial back when it was first created. And then in the 90s and in the early 2000s, it went up to like $1,500, or no, I'm sorry, like $500 for a vial. And then the pressure from states like Maryland and the federal government came to set caps on co-pays for insulin. And Eli Lilly, who makes insulin, actually lowered the prices of their insulin. So perhaps that's one example of how this public policy can make a difference in the pricing chain.
I have Delegate Hutchinson, followed by Delegate Chisholm, followed by Delegate Martinez, and then Shalala.
Thank you, Madam Chair. Madam Vice Chair, if you recall during the briefing we had, I had asked Mr. York about who actually is getting the savings. Is it the consumer, then they go up to the counter? Is it the state plan? And I got an interesting answer, but you helped me clarify it. Could you help me with that again?
Sure. As the board exists now, the savings will go to the state, back to the state, healthcare plan. And whatever savings we have could go in, I'm it could go into the general operating funds. I would hope it would go back into healthcare services, but that savings we haven't seen yet. So, but it only goes back into the state healthcare plans and the local healthcare plans. What we're proposing is that the same upper payment limit be applied in the commercial market. And as Delegate Kipke pointed out, that's about 20% of the market in Maryland. And the way that it would work for a consumer is if the commercial market insurance companies have a lower drug cost, then they can apply that to premiums. And in fact, they have to, because they can't spend more than 20% of their income on administration. So it can go back in premiums, or they could decide to do different copay and coinsurance structures, depending on how much money they save. So it could happen either way.
So the example of the witness to your right, how would this bill help her situation that she described in her testimony?
Well, what she's describing is that the drug is too expensive. She's not insured, so she can't go to the counter and buy the drug that she needs. It's too expensive for her. If she were insured, then again, the impact would be either on the premium or on the copay structure.
Thank you. Thank you, Madam Chair.
So next we have Delegate Chisholm, followed by Martinez.
Thank you, Madam Chair. I think if you were to poll this room, it would be 100% that everybody in here understands that prescription drugs are extremely expensive. They're prohibitive to some people. It's a tough situation. The real question then lies in why and how do we really fix the problem? My question, before I ask the question, I do want to, for the good of the order, we got insulin in 1922. We started taking it from dogs and then it moved to pigs, but we have evolved insulin. Insulin has gotten much better. It's much quicker reaction. Being a type 1 diabetic since I was 9, they have improved. Not a dramatic improvement, but your point is made. I understand that. My question is more for Dr. York. You gave this committee a briefing on January 15th, and in their key takeaways, the first takeaway is complex supply chain that may cause market failures in different circumstances, which is obviously is a concern that all of us have in here. A drug doesn't work if you can't afford it. A drug also doesn't work if you don't have access to it. So my question is, with that report, and I never went back and looked at the report, can you pinpoint some of the complex supply chain issues that you saw that you think you could fix that would result in lower prescription drugs?
Yeah, I think one of the key takeaways from the report, and one item that we like to reference often, is this dynamic of the difference between the gross costs and the net costs. And I think this is a frustration for everyone in the supply chain, though no one has taken steps to fix it. But going back to the insulin example, what the manufacturers will say is that the drug, so for your most modern insulins, they came to market at about $100 in the early 2000s. By the 2020s, they were $400. But if you talk to the manufacturers, they would say, actually, we're still getting $100. What happened is there's this $300 of rebate that needs to get paid to the PBM to get a priority placement on their formulary. So when I say that there's a complex supply chain, it's that there's these dynamics that create perverse incentives in a way that you wouldn't just expect in just a normal competitive market of you give it to the highest quality, lowest cost product, right? So that's kind of what we see, and that's also, why we need to look at what the driver is. A perfectly reasonable outcome of this process is we look and then actually get to see what the true cost of the drug is to the healthcare system, and then identify, oh, actually, we see this very high gross spend, but the net spend is actually completely reasonable. That's a reasonable finding. Or, insurance coverage is great for all Marylanders, and the cost is low to the patient, so that's fine. Or there's patient assistance programs for anyone that needs it. Every patient that needs access to it can get that. That's fine. So these are all different circumstances where it could be affordable in circumstances, even when it does, to us, at first glance, look at a high cost drug.
Example, and so if I heard you correctly, the manufacturer a lot of times is getting the same money, but there's all these middlemen in the middle, and that's what's driving up the cost. You just can't always identify it. I'm assuming you're talking PBMs, you don't always know, but the manufacturer, if you take your insulin reaction, you said, or insulin example, you said they're still getting $100, but now we have all these drivers in the middle that are pushing the price up. Would the upper payment limit all those middlemen?
It is a tool, so it depends on the circumstance, but there are scenarios where an upper payment limit can be used to address some of the perverse incentives that come through that dynamic. I also just want to say I was reflecting my manufacturer colleagues, like I think this is the story, what they would tell, and it's difficult to verify. So like in the insulin example, I think the only reason we know that is because there was a Senate Finance, I think it was Senate Finance hearing that actually got to like open the books and see, but for most drugs we can't see. So this is a story that we hear and we generally believe it, but I'm not sure that that's true. But upper payment limits can help to address some of the distortions that come in some of those extreme examples, yes.
Okay. Thank you. Thank you, Madam Chair.
You're welcome. I have next Delegate Martinez, followed by Shalega.
Thank you so much, Madam Chair. I'm excited we're using AI in committee, especially since we're the committee that regulates it. So my good friend ChatGPT, I asked it a very simple question as well. I said, does our healthcare system here in America work when it comes to pharmaceuticals? And it gave me a list of a whole bunch of things around innovation, around some of the regulatory oversight, choice and availability, but then it talked about high prices. And then it asked another question if I wanted to get specific about Maryland, right? It knows me, it knows I'm from Maryland, it knows I'm a legislator in Maryland. Yeah. It knows a lot more than it should.
Sort of like Elon Musk.
One of the things it said is that we should expand PDAB's authority to allow the board to regulate prices for all residents, not just government employees, and this would help Marylanders afford essential medications. Isn't that so?
Yes.
If ChatGPT says it must be true.
Thank you.
Shalega, take us back to the serious thing.
Thank you. Thanks, Madam Chair. Thank you all for being here. I have a couple quick questions. Dr. DeMarco said that this is going to save state and local governments, and then our vice chair said the savings are going to the state budget. And I'm looking at your billboard here, and it says profits over patients. Should it say state profits over patients? Because what you're telling me is this doesn't deliver any savings to a patient.
Well, may I, the present law, as you wrote it in 2019, allows the board to only put upper payment limits for state and local governments, which will help all us taxpayers. In order to help the patients, you need to pass Delegate Cullison, Delegate White Holland's bill to allow the board to help everybody. That's what will help patients. This chart relates to what was said earlier by Vice Chair, that the drug corporations now spend $20 billion more on profits and advertising than on research. So you are right that the present law only helps taxpayers. To help patients, you need to pass House Bill 424. And before, I just want to say, Tammy Bresnahan is not going to be able to be here, but she says the AARP is 100% behind this.
Well, AARP is mostly Medicare, so this isn't going to help them either. But, you know, with all due respect, why didn't the state pass it on to patients? And if the state didn't pass it on to patients,
Give me 1 second, please. Someone is leaning against the light.
Oh.
It's
There we
okay,
go.
it happens.
That was dramatic.
Yeah,
dramatic, yes.
And you know what? It's the Delegate Shalega wanted a little drama. Go ahead, Delegate Shalega.
Because if the state wasn't willing to pass savings on to the patients, everyone in this room, everyone there, everyone here, we all agree. We want patients at the counter to have affordable drugs. You told me what we have doesn't do that. It only saves the state. There is nothing in this bill that would say the 20% of commercial payers wouldn't do the same thing.
Well, that's what Vice Chair Cullison read the statement by our wonderful new insurance commissioner, saying that they would pass it on to consumers at rate review time, that if there's an upper payment limit that the board sets for commercial payers. At rate review time, the insurance commissioner would make sure it gets passed on to consumers. But I also want to talk about ERISA for my friend, Delegate Kipke. Okay.
Let's not go there.
Okay.
So, you know, why I respectfully disagree with you, because they could put it right back in the general fund of the insurance company. So we agree on where we're going. Some of us may disagree. I mean, it's not working now, and it's not because we aren't including 20% of the patients. Thank you. One other quick question. We've had a lot of discussion about, you know, the Larry Hogan's to blame because he vetoed it, blah, blah, blah. Well, I looked it up. I went back. The PDAB has been meeting since 2020, 6 meetings, and there have been 40 meetings over 4.5 years, not every month. Matter of fact, you don't have one in February, which is puzzling, but nevertheless. Have you recommended a UPL for any drugs in 40 meetings?
We are in the process of so we can start UPLs after our regulations are finalized, and those are up for comment until February 10th, and then the board can finalize those. So there's no process for us to set UPLs, but that process should be established in the upcoming months. And then also just wanted to respond to your comment on the savings not being passed on to patients in the state. And that's an artifact of the state almost exclusively having copays. So like a Medicaid patient is paying $1 to $3. In the state, the employee health plan is very generous. So they pay, you know, $5, $10, $15. So that's the only reason. And it may be reflected in premiums to like there will be potentially reduced premiums to state employees, but it's just an artifact of how the plans are designed for the state that we're working with. That
right, but my point, Dr. York, is this has been portrayed as delivering savings to patients at the pharmacy counter, and that's not what we're saying. So I was just clarifying that we're, you know, it's saying one thing, but doing something else. Thank you.
Great.
All right, we have next Delegate Hill, followed by Delegate Woods.
And thank you all for the work and for being here today. I'm going to address this to Mr. DeMarco unless the sponsor wishes to take it. There's been questioning about models, and we've talked about European models. But my understanding, so correct me if I'm wrong, is that we have models here in the U.S. We have, number one, the model where the federal government says for providers accepting Medicaid or Medicare payment that you can charge whatever you want. This is what we're going to reimburse you.
Yes.
And over decades, the result of that has been that the independent insurers who do not have to subscribe have lowered their prices to match those lower reimbursement rates. It has set a floor that they have all scampered to meet. The second model we have is that the federal government says to Medicare providers, you cannot charge a Medicare patient more than the patient you charge the least. So that as a provider, I may have paid Blue Cross differently, independent folks, people who have no insurance differently, but they say that Medicare has to be my lower. So equivalent for us would be, we provide money for research. You can't charge Americans any more than the country you charge the least. And we also have models that states have used where they have done subscription model agreements, like the Netflix model, correct? Where, say we want to get a hepatitis drug, and we will go to the market and say, this is what we can pay, as the vice chair said, for this hepatitis drug that we want to bring in. Do any of you manufacturers think, and are you willing to accept this price if we'll buy this volume? And that works as well. Are those models that we have that are similar to what we're doing here? Either DeMarco or, yeah.
So I would say that, yes, I think those are all kind of frameworks that we can look at. The federal government, and Medicaid actually, certainly gets prescription drugs at a much lower cost than what we're seeing. And I would say that Medicaid is probably comparable with what other countries are seeing, partially because of how that program is designed. And then you mentioned the Netflix model, which I think is a good example of a market-based model. This is a negotiation with the manufacturer that we come to an agreement on what a set price would be to provide the full need of the state. So I think it's a very innovative and strong model, one that I think our board would consider in the future. And then there are other models you can look at too. You can think of the Medicare Inflation Reduction Act, the Medicare negotiations out of that. And then 2 states, their Medicaid programs have models that are very comparable to what we're doing. The New York Medicaid program and then the Massachusetts Medicaid program have programs where you specifically look at specific drugs, evaluate them, and then get supplemental rebates back to the state.
So we're not making stuff up. This is stuff that's been done. It works in the markets. May I have a follow-up, Madam Chair? Thank you, because I also queried ChatGPT.
Busy today.
And my question was, what are the risks of exorbitant, unregulated pricing? And ChatGPT said, 1, consumer exploitation, overcharging, inequity. 2, market distortion, monopolies, and oligopolies, barriers to entry. 3, decreased consumer trust, loss of confidence, brand damage. 4, economic inefficiency. 5, social unrest and political pressure. 6, negative impact on public health and safety. Inflation. But that seemed to be consistent with some of the things that we're seeing here in Maryland that this board and this body is trying to address.
Yes.
Thank you. Thank you, Madam Chair.
My pleasure. We have next Delegate Woods.
Thank you. I do not have anything from chat. GBT, but I do have a request from a constituent who resides in my district who's currently watching the hearing and would like to ask this question. Why do Marylanders have to wait for the PDAB to generate savings before they get relief at the pharmacy counter? Why not pass legislation now that requires insurers and PBMs to give patients the benefit of the cost savings from drug rebates and patient assistance programs?
So that's another bill. It's not on
So that's chat
UPL.
constituent.
Yes, yes. And ask your constituent to watch the hearing on the copay accumulator bill, where they will be able to take that.
And if I may interrupt for a second, just to follow up, will you give a little history of what happened with that bill last session?
So the accumulator bill would allow for any discount or subsidy that an individual receives from a drug company to go towards their deductible for the year. So they could potentially meet their deductible in the first 2-3 months of a year if they're paying, with the subsidy that they're getting. Because some drugs are subsidized 100%. Some of these expensive drugs by the manufacturer. So we, in the House, said we need to make sure that it's going back, that it's going to the the person in the form of the deductible payment, but we also needed to know how long the discount or subsidy would last. Because we've had situations where consumers were given these subsidies and discounts and rebates, and so they were paying, $10 for 3 months, and all of a sudden they get to the pharmacy counter in the 4th month, and it's $300. And I had one instance where a consumer told me that she actually called the manufacturer and said, "How did this happen? How did I go from $10 to $300?" And they said, "Well, your discount ran out." And she said, "But I was never notified of that." And they said, "We don't have to notify you of that." So our bill included that notification, and the bill that the House passed included that. The Senate chose not to include it. And we felt that the bill did not serve consumers well enough under those circumstances. And I will say, there is language in other state bills that have done the accumulator bill that says the patient will be notified of how long it lasts. So it exists out there.
And that bill is coming back this year.
It's coming back, yes.
That's what we're going to try again. Any other questions? I don't see any from anyone. I just want to thank you all for the work you're doing. I want to thank everyone for being patient. We're now going to go on to an unfavorable panel.
Thank you, Madam Chair.
My pleasure, thank you. Next, as I call you, will you be so kind and come up? If there are not enough chairs, please pull one. I'm going to start with Kristen Party from Pharma, Russell Polk, Dominique Daniels, Tamika Johnson, and Marquita Goodluck. And when you have a seat, if you can please determine who's going to go first. And you may get started. Just as a reminder, you have 2 minutes to provide your testimony. If the alarm goes off, please just wrap it up. And good afternoon, everyone. How are you?
Good.
Wonderful. Who would like to get started?
I will.
All right, thank you.
Madam Chair, members of the committee.
And will you be so kind, and pull the microphone really close to you? Delegate White Holland would appreciate it.
But I know not to press it.
Go ahead.
Is that better?
Yes, thank you.
Okay, great. Good afternoon. My name is Kristen Party. I'm Deputy Vice President of State Policy for Pharma. Despite years of work, no state has implemented an upper payment limit, as we've talked about this morning, and there's a good reason for that. Expanding UPLs would further disrupt the pharmaceutical supply chain and threaten patient access to needed medicines. UPLs create uncertainty in a complex system, making it harder for providers to secure medications at state-prescribed prices, leading to treatment disruptions or inability to access medicine for patients. That's why patient advocates and healthcare experts have urged states to reconsider. There's growing acknowledgement that UPLs won't lower patients' out-of-pocket costs, which we've been talking about this morning. Meanwhile, PDAB's focus on, the UPLs is diverting attention from these real affordability issues, namely the role of pharmacy benefit managers and insurers. PBMs and insurers determine how much patients pay. They set the price of deductibles. They set the price of coinsurance. They place restrictions on medications, not manufacturers. Yet the cost review process and UPL action plan has yet to address these critical concerns. Rather than expanding the PDAB scope, we urge the legislature to evaluate the possible negative impacts of UPLs and focus on immediate pro-patient solutions that address affordability, some of which we've talked about this afternoon. Thank you for your time.
I can go. Excuse me. Madam Chair and members of the Senate Finance Committee, thank you for the opportunity to speak today. My name is Tamika Johnson. I have been a Marylander for 40 of the 43 years of my life. I'm a mother of a beautiful daughter named London, a retired special educator from Maryland public school system, author, blogger, and patient advocate living with metastatic breast cancer. My journey with cancer began just at 13 years old when I was diagnosed with osteosarcoma. After 18 years of remission, I was diagnosed with stage 2 breast cancer, HER2 positive, at the age of 31. In 2016, I learned the breast cancer had metastasized to my left lung, my left collarbone, and my lower spine. As a single mother living with metastatic breast cancer, I especially rely on timely access to treatments to stay alive. This is why I'm here today to express my deep concerns about HB 424, which would expand the Prescription Drug Affordability Board's authority to set price caps on medications. Let me be clear. Maryland policymakers are pushing to expand the PDAP program, even though patients like me have made it clear that it isn't working. If this program is truly about helping patients, why aren't they listening to us? The PDAB has been in place for 6 years, and in that time, it has cost taxpayers over $3 million. Yet patients like me haven't seen a single dollar in savings. Instead, we're left worrying about whether policies like this will create new barriers to treatments we need to survive. When you're going through cancer diagnosis, you are already worried about a million things, whether you're going to survive, how much time you have left, and left with your children and loved ones, and how to navigate the physical and emotional toll of treatment and process as a whole. I urge you to oppose any efforts to expand the PDAB's authority because it does not meet what it was created for, and that is for the patients. Instead, I ask that you focus on policies that truly lower costs for patients at the pharmacy counter while safeguarding access and the innovative development of treatments we need to survive and thrive, because my life depends on it. Thank you for your time.
First of all, on behalf of the committee and our team, I want to thank you for sharing your personal story, okay? We really appreciate it. And I pray that it all goes well, okay?
Thank you.
You're welcome. Who would like to go next?
Okay.
Thank you. Will you be so kind and pull the microphone closer to you? Thank you.
Hello, everyone. My name is Dominique Daniels. I am a Crohn's patient. One of the medications that is up for this discussion is Skyrizi, which is a medication that I currently take that I have reached remission while on. So I urge the board to think about patients, because we are what this bill truly affects, like not just our pockets, but our lives. Yes. When you make these decisions, you don't realize how much the patient is affected, because our insurance companies can easily say, denied. And what do we do? How do we live? It's not only affecting our money, it's affecting how we take care of our kids, how we survive, how we live. So please, 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 I urge you guys to really, really think this over and think from a patient standpoint. Is it benefiting patients? Because I have been on the side of being denied access to a medication that I needed. Thankfully, Skyrizi was an option for me, but I know so many people who their insurance just denied medications and they're suffering. And nobody really thinks about the patient that's suffering during that time. We can talk about money all day, but you can't get back that person's time, that person's life, that person's time away from their children. So I just ask that we think about those things as well. Thank you. Thank you.
I'll go next. Madam Chairwoman and members of the committee, thank you for the opportunity to testify today. My name is Marquita Goodluck, and I'm a 7-year breast cancer survivor, advocate, and author. At 35, I was diagnosed with stage 2 estrogen receptive positive invasive ductal carcinoma. My journey has included surgeries, radiation that resulted in severe burns, and the immense challenge of navigating a healthcare system that too often leaves patients uninformed and unsupported, especially when timely treatment is critical. My personal experience inspired me to write books to offer solace and support to other patients and families facing a similar diagnosis. But my advocacy doesn't stop there. As a Black woman with a genetic mutation, I've seen firsthand how health disparities and systemic barriers disproportionately impact communities of color. Furthermore, my ongoing treatment within the breast cancer community, ongoing engagement within the breast cancer community keeps me acutely aware of the challenges patients face daily. This lived experience, combined with the fact I'm a survivor who is still in treatment and reliant on hormone therapy medications to keep my cancer from returning, fuels my deep concern regarding HB 424, which proposes expanding the Prescription Drug Affordability Board's authority to set price caps on medications. This legislation could make it harder for patients to access the treatments they need to survive and manage diagnoses like breast cancer. And while the goal of lowering drug costs is important, the PDAB has yet to deliver on this promise. Despite its 6-year existence, the board has yet to demonstrate any tangible savings for patients. In fact, it has cost Maryland taxpayers, including myself, over $1.4 million in 2024 alone, funds that could be directly invested in patient care and support in helping patients like myself. I ask you, how does this help us? As I've stated before, until these boards genuinely represent patients and critically the Black and brown communities so disproportionately impacted by health disparities, we risk creating policies that are ineffective and perpetuate existing health inequities. Meaningful progress requires that all voices have a seat at the table. Expanding the PDAB's authority without ensuring diverse patient representation risks creating policies that completely miss the mark on addressing the real-world needs of marginalized communities. Thank you.
Are there any questions? Delegate Shalego.
Thank you, Madam Chair. Thank you all for being here. I'm sorry to hear about your health difficulties, and we're really proud of your bravery to come and share them with us. So you all spoke, and just one person gets to answer, about how you're disappointed that this PDAB has not delivered savings to you at the pharmacy counter. Do you think that's because that was never the aim of the legislation? While, you know, it was a lofty idea, perhaps it's because the objective of the PDAB wasn't to specifically deliver savings to you, it is to deliver savings to the state government.
Go ahead. You answer? Go ahead, I'll let you answer.
Yeah, I think that's exactly right. I remember when the bill was being debated in 2019, and certainly I believe most constituents believed that it was to lower their drug costs. But it's clear, as this process has continued, that that's not how it would work. Now, expanded, then you're bringing in commercial insurance, and I guess there's an assumption that they would start sharing any savings, which they're not really doing right now. We've had the Share the Savings bill last year and other things to really hone in on those rebates. There's $334 billion each year in rebates that are not being passed on to consumers to lower their costs at the pharmacy counter.
Thank you.
Okay. Delegate Bandari.
Thank you, Madam Chair. Christine from Pharma. You had a concern about the drug shortage. Like the U.S. government created the 340B drug pricing program back in 1992 to help to provide outpatient drug at significantly discounted prices, and that successfully lowered the cost. Why do you think that this PDAB will have that effect? I know it will take a while to see the result, but we already have seen that.
Well, that's a really interesting question. So when you look at 340B, that program was started to fill a hole that was created when Congress started the drug rebate program. So prior to that time, pharmaceutical companies were offering discounted medicines to safety net hospitals and other clinics, but they were no longer able to do that when there was best price. So that started, and it's an entire pricing program based on the companies giving this, discounted prices, it's about like 40%, to a lot of hospitals and safety net clinics, and that helps them, survive and exist, and in theory, pass down that pricing to drugs. But what we found is that in most cases, particularly with hospitals, which take up about 80% of the 340B medicines, the drugs are not being, the savings are not being passed on to patients there either. So I think that's just a similar problem where you're having this hope that these, large corporations, hospitals, pharmacies, PBMs would share the savings with the average consumer.
I think may have one question. Yeah, another question. We talked a lot about the research and the proponent of the bill. They talk about the new research, when I was looking the research, a 2021 report from the U.S. House Oversight Committee found that major pharmaceutical companies spend more on stock buybacks and executive bonuses than research and development. Do you have any comment on that?
I've heard a lot of this morning talking about the spend on marketing and distribution or salaries. I know stock buybacks has come up before in this committee, and it's simply not true. The average pharmaceutical company invests about 20 to 25% of their profits back into R&D. They're one of the highest advancers of R&D in the entire country, and oddly enough, with not the same profits as you would see in, say, an Alphabet or some of the more tech things, because as we've discussed, there's an 88% failure rate. It's such a high-risk proposition, and it's very costly. It's $2.6 billion, 10 to 15 years. And so that's, a huge investment. And I actually just looked it up. It's 2020, so not the same year as you, but the numbers were about $122.2 billion in R&D for the pharmaceutical companies, and of that, $33.3 billion is marketing and distribution. But keep in mind, that's going to include rent, salaries, shipping, all that sort of stuff. So when you're looking at the actual direct-to-consumer advertising, in that year, it was more like $6.6 billion, which is obviously a very large number. But keep in mind that direct-to-consumer advertising is how a lot of patients have been able to realize that what they're dealing with isn't odd. It also helps them hear about drugs that their insurers likely aren't covering, so they know to advocate for themselves. So there's a lot of benefit to being able to get that information out there so people know about the new innovative medicines.
Madam Chair, promise this will be the last one. Sure. Yeah, so you talk about R&D, and publicly funded institution like NIH plays a very crucial role in drug development, often bearing the highest risk cost on the early stage research. And the drug companies then acquire their innovation and market them at extreme prices. And taxpayers already fund much of the innovation. Do you have any comment on that?
In many ways, they're partners. I mean, NIH does a lot of research, is what you would say, sort of like the beginning research of things like that. They need to partner with investors in private biopharmaceutical companies to be able, who have the resources and who have the technology, who have the brilliant minds to be able to bring it to the next level. If you look at the NIH budget, only about 8% of what they do is on actual brand clinical trials. They're doing a lot of other things that they're looking at, whether it's devices or just overall research on human health. The actual medicine clinical trials is a relatively small portion of it. But that is not to say that they are not a wonderful partner, and it's a key relationship that has been very successful. But the amount of money is not even equivalent between the private industry and the NIH.
I yield, Madam Chair.
I have Delegate Riley. You're welcome.
And thank you for the panel being here. I'm glad you're all very healthy to be here and visit with us today. So clearly, you've already stated that you're a little disappointed that there's no savings passed on to the actual patient at this point. That may change, but we don't know at this point. But also, as I was listening to some of your testimony, are you also with if we came up with this upper payment limit on these particular drugs, especially some of the drugs that are, very scarce and very limited to certain infectious diseases and things of that nature. Are you afraid that with this, the availability or the supply chain of the actual drug itself, patients would not have access to because of the limited amount that, the pharmacy or the manufacturer may get within the state? Whoever best, one person.
I can answer that question.
Sorry, one
yes,
person.
It is definitely a worrisome thing for us because.
Could you move closer to
I'm
the
sorry.
mic? Sorry.
This is definitely a worrisome thing for us because we just don't know. For instance, I'm on a biologic medication, so I can't just stop taking the medication. I will feel it literally if I just stop taking the medication. So yes, we are definitely worried about access to these medications if this bill is passed.
Thank you, Madam Chair.
Delegate Hill.
Thank you. Thank you all for sharing your stories. I know it's difficult. I appreciate your advocacy, and just want to assure you that I think every member of this committee really wants to make sure that people have access to the medications they need, which means that it has to be affordable. I wanted to ask, I'm sorry, tell me your name again, second?
Tamika
No,
Johnson.
next to Ms. Johnson.
Kristen.
Kristen, let me ask you, I'm looking at an article from the Pharmaceutical Research and Manufacturers of 2025, article about the 340B, and they basically say that currently there are, this is quote, over 33,000 distinct pharmacies participating in the program known as contract pharmacies, and while one might expect to find 340 contract pharmacies located in medically underserved neighborhoods to help vulnerable patients, which is why it was developed, access medications, that isn't the case. Studies have found the exponential growth in contract pharmacies from 2011 to 2019 was concentrated in affluent and predominantly white communities and not in areas of high unmet need. It then goes on to say PBMs now own the majority of pharmacies nationwide and make the largest share of their profits, 55%, from their pharmacy business. They use the 340B program to drive that profit, and there are more than 94,000 contracts between 340B provider and pharmacy with financial ties to one of the three largest PBMs, CVS Health, Express Scripts, and Optum prescription, more than 50 cents of each dollar in profits. They then go on to say, or to ask the question, or posit the question at the end, if the money isn't going to help patients, where is it going? So I'm asking if you want to comment on that. And second of all, don't the pharmacy or the manufacturers, rather, don't the manufacturers already have the ability to lower that price for the patients? If they wanted to do it now, it could be done.
I think, well, let me start with the 340B one, and I'm familiar with what you're referring to. And yes, that is what's been happening. The program has grown extremely over the years. It started with 44 hospitals. It's now a $66 billion program just right after Part D. And a lot of how it's happened, where you see it moving more and more into these affluent areas, is because hospitals that are 340B are able to purchase other things. So a lot of what you'll see is they'll purchase like independent cancer centers, physician practices, and they do that in affluent areas because that's where the highest percentage of commercially insured people are. And so when a 340B entity purchases a 340B drug at the very, very, very discounted price, they will still go ahead and charge the insurer, the patient, the same price. So they could then pocket that big spread between the two. They're not required, as I said, to pass that discount on. So, probably all of us have been a 340B patient at one point. Most of your hospital systems are. So if you've been there and received a drug, likely you are. But they're just doing what they would normally do with your insurance. Same with if it was just an individual pay. So there's an incentive to move into these areas because it's a real profit maker. And the program itself has become very profitable to these large systems, to pharmacy benefit managers, to pharmacies, and as you said, they're all often the same. There's only a few. They're vertically integrated, so you'll have an insurer who is also a PBM, who is also a large pharmacy chain, and then sometimes is even a provider. Could you, and the second question, is that the?
Right, so the question is, if money isn't going to help patients, where's it going? And do not the manufacturers have the ability, if they wanted the patients to see lower costs, whether they want it in Germany, or they want it in America, or they want it in Canada, do they not have the ability to say, we're charging less and we will take less profits? So whether there's a PDAP or not, if they wanted the patients to pay less, and if profits were not their primary concern, do they not have the power to do that now?
Because of the way the supply chain is, it's actually not that way. There's a perverse incentive to have a higher list price because pharmacy benefit managers get the rebates. And those rebates, you're looking at over 50% of each healthcare spend, each dollar, goes to middlemen, primarily pharmacy benefit managers. And so a pharmaceutical company could lower a price, but if their PBM is not getting the same amount of rebates, they might not cover that drug. And they are free to not cover any drugs that they do not want. And so it gets to be a very, very complex system that we have said as an industry needs to be reformed. I mean, it's in terrible need of reform. But that's why it isn't quite as easy as just lowering the price. They might not even get coverage then.
Right. So the PDAP's not the problem, but it might be part of the solution. But thank you. I appreciate it. Thank you, Madam Chair.
All right. I have Delegate Lopez.
Thank you, Madam Chair, and thank you to the panel for sharing your stories today. And I'm so sorry that you've had the health challenges that you have. And we just appreciate you being here. My question is for Ms. Party. Everyone has kind of mentioned the unintended consequences of the Prescription Drug Affordability Board and the upper payment limits. Could you explain in a little bit more detail about how or why a manufacturer might refuse or to sell?
So it's more so, when you look at what the upper payment limit does, it restricts how much can be paid, not how much can be sold. And these, prices are set nationally. Maryland would be an outlier, say, if it chose to say, okay, you can only pay this much for this medicine here. If that's not what is being, if that's not like the market price for it, then in theory, it might not be available. Obviously, we say in theory, we don't know, but it does place payers and providers and pharmacists in a situation where they could even have stock left over that they can't be reimbursed adequately for because they can't, because of the price being lower to a new reimbursement rate. It really gets complex with the market system, honestly.
Yep, sounds like it. Thanks.
Morgan, you going for a second bite? Is it first bite on this?
First bite on this.
Oh, on the unfavorable, that's right.
Second bite of the day. And it is making kind of hard.
It's okay, go ahead, Delegate Morgan.
Thank you, Madam Chair.
You're welcome.
Something my colleague just said that kind of caught my ear in your response there from Pharma. Would there be any danger if this bill was enacted? You said Maryland would be an outlier. If there was a drug that was considered high by the PDAB board, could the manufacturer just decide, well, you know what, we can't sell it for that price, and we're going to sell it in 49 other states, but not Maryland?
They'll be offering their price, the same price as always. Then it's on the part of the Maryland payers of whether or not they are able to meet that price. I mean, that's the way the whole PDAB system, the upper payment limit, is set up.
But if it said, so let's say a drug was like $200 and the upper payment limit says, well, you know what, we're not going to pay $200. We can only pay $100. And the manufacturer's like, well, I'm not willing to sell it for that price. Could the manufacturer make that decision and say, you know what, we're just not going to deal with Maryland and result in rationing, and we'll sell it somewhere else where we can actually get the price that we're willing to pay for it?
Yeah, I mean, it would be more so not that we won't sell it, we'll just say this is the price. If that price does not match the rate that's been set, or that would be reimbursement rate, then it just wouldn't be available. It's not that the drug manufacturer is not making it available, it's just that the price that the state has said payers can't pay or have to pay is not enough.
Gotcha. Thank you. Thank you, Madam Chair.
Any other questions for this panel? So I am going to first say thank you, and I want you to know that we respect your testimony today and that we are grateful that you share your personal experiences. But I am going to say, I want you to leave here knowing very clearly that the intent of the bill is to help. And as someone who put in the bill initially, I wasn't going to speak, but since everybody's inferring what the bill did and didn't do, I want to clarify for the legislative record. I put in the bill in 2019 for this reason alone, because there were people, my constituents, who were making decisions every month whether they could buy their medication or pay their mortgage. And then I learned about how it worked. And I started researching and learning that the prices in this country are so much higher than in other countries, and that they're the same companies and the same drugs. And I learned that America has the worst outcomes for a patient than a lot of countries, and it's more expensive. And I learned that the federal government wasn't doing anything, and they're not gonna do it. We could see the chaos we have right now. And that it's really up to the states to be brave and do it, even when they take us to court, because it's the right reasons. So I put it in for that reason alone. And I want the record to be clear, with all due respect, that the reason why the board is not more advanced in their decision-making is because it was created in 2019 when I put it in, right? And then what happened, usually when you put in a bill is signed into law, or it can be vetoed. So at that time, the governor decided to veto it, and I respect that. So what does the body do when a bill is vetoed? A body has to bring that bill back and do a veto override. So it went 2019, it got introduced 2020, the funding bill was vetoed. 2021, we did a veto override, so it took us 3 years, right? Then 2022, we were able to choose the last of us, the stakeholders. So the board has 5 board members, and then it has 26 stakeholders, and it has the entire pharmaceutical, industry chain, so that everyone can give their opinion. So 2019 introduced, 2020 bill was vetoed. 2021, we have to override the veto. 2022, we have to choose the stakeholders. And it takes time because the secretary of appointments have to appoint people, and they have to be vetted, right? And they have to have the experience. 2023, finally, they're together, and they're trying to make this decision. The way it was introduced originally was only for the state. It was a pilot. And why do we do pilots in the state? Well, we do pilots because sometimes we want to show that it works and that the sky's not going to fall, right? And then it was decided, you know what? We could still continue to do that work, but open it for everyone else so everyone can benefit, right? So I too did an AI, GTI, and I asked the question, can drug manufacturers lower drug prices? Because we didn't get a clear answer. So this is what GTI said, or AI. GTP, okay. As you can see, I don't use it. I never use it. I'm gonna have to start using it. It says, pharmaceutical manufacturers control their drug prices, and they alone can lower them for Americans today. They can do it. Yes, we have everything else, the PBMs, and trust me, this committee is dealing with them too. And I would like pharma, I expect pharma, respectfully, to come and testify on those bills, because it's important. And they say instead, they continue to raise prices year after year, even several times a year, making healthcare more expensive for everyone. And I finally want you to leave here knowing that this is the committee, as a person of color, that declare racism as a public health crisis in the state of Maryland. This is also the committee that requires implicit bias training for all healthcare providers in the state of Maryland. And by the way, I put in those bills as well with the support of my colleagues. And this is the committee that created a commission on health equity. And I have to tell you that I, myself and this committee, work very hard to make sure that the drugs you get, and every patient, because you're going through hell when you get a diagnosis like that, and the last thing you need or deserve is to have to deal with a denial or with the prices. In this session, I would love, and I'm inviting you respectfully, to come and give testimony on a bill I have that is gonna deal with denials. When insurance company deny you, it's gonna deal with that, and I need your voices, because it's important. This is a complex system, and we're just trying to find a solution. Is it perfect? Maybe not, but we cannot keep our arms crossed. But I don't want you to leave here thinking that we do not care about you, because we do. You are the reason why we get up, we wake up, praise God, and we work hard, okay? And I want you to come and give me your voices on the issues that we have on this committee. And I hope you have a blessed afternoon, and thank you for being here with us because we value your testimony. Thank you so much.
Thank you.
Next, we are going to go on to a favorable panel, and I'm going to go back to the unfavorable, okay? So next, we have Larry Sarseski, who I know well for like 17 years. And we have Kim Phelps, Denise Gilmore, and I have Lorraine Aricott. Will you be so kind and come up, please? Good afternoon, how are you?
Good afternoon.
Good. Larry, would you like to get started?
Thank you, Madam Chair.
Yeah, and take your time, all right? And please put the microphone closer to you. Okay.
Good afternoon, Madam Chair and distinguished committee. My name's Larry Zarzecki, and I have a neurodegenerative disease that there's no cure for. But before I go into that and speak a little on that, I also want to thank each and every one of you for being here today and inviting me. I would also like to extend my gratitude to Delegates Cullison and Delegate Holland White for their support of this bill. Thank you all so much. Madam Chair, you pretty much summed up my entire testimony. The only thing I can really add to what you had to say was it's time to untie the hands of the Prescription Affordability Board. I sat here and I listened to a representative of the pharmaceutical company that said, yes, sure, we could do it. They're not going to. I also listened to a very brave lady. I couldn't tell which one of the ladies it was because their backs were to me. Say she was afraid. That says a lot. Why are you afraid? Well, she was sitting here, and I don't mean this in a bad way, because if I could sit in front of the leaders of the pharmaceutical companies, I would say, thank you. Thank you for your life-saving drugs. Thank you for all of your hard work. Just like I'm thanking each and every one of you for considering House Bill 424. The only thing I can really add is, once again, I'm faced, because of the economy, whether to heat my home, to treat my condition, or to have some nourishing food. Well, when we're making those decisions, when we can walk down a junk aisle and get foods that are full of preservatives rather than organic, that makes a difference. We'll pick up a can of soup that's loaded with sodium and increase our blood pressure, and it's poor for our health. So there are a lot of factors that I wish could be understood. I also would like to just very quickly add, and then I think I've pretty much given all of my testimony. I speak to a lot of people every week, and they're very patient with me. And when we go out into the field and we talk to people and they ask the question, why haven't we seen anything yet? The explanation is very simple. Well, when we tell our child, clean your room, 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 if they just keep putting it off, putting it off, putting it off, the room is going to get dirtier and dirtier and dirtier. So I guess what I'm trying to say is I am respectfully asking, as a person who walks in the shoes every day of not being able to afford all of my prescription drugs. I have one right now in my bag that's empty because my insurance, and I have good insurance, they don't cover it. They don't cover it. It's $936 for a milligram. A milligram. Now think about that. $936 at the pharmacy counter because the pharmaceutical company doesn't want to reduce the price because they hold the patent right now. I was looking forward to the new pain-killing drug that's coming out next month. Insurance probably won't cover it. It's the first opioid-free pain relief medication for prescription use in 20 years. So that should be interesting. So I would like to respectfully ask to please consider untying the hands of the Prescription Affordability Board so that they can do the job they were meant to do and not keep allowing the pharmaceutical companies to use smoke and mirror tricks to confuse people. I think Maryland is very smart the way they've approached this, very methodically, and that is all I have to say. Thank you.
Give you a little time because I know it takes you a little time. All right, and we try, everyone here gets the respect that Larry gets, okay? This is a committee that cares. Next, please. And thank you, Larry, for sharing your experience. Go ahead.
Sure. Good afternoon. My name is Denise Gilmore, and I'm the Legislative and Political Director with AFSCME Maryland. We represent 45,000 state, county, and municipal employees. In the interest of time, I will largely me too all of the favorable testimony that came before me. I do just want to say, we are in full support of the work that the Prescription Drug Affordability Board has done to this point. We're particularly impressed that they've chosen, an anti-diabetic to review. Sponsors did a fantastic job. Alluded to the skyrocketing costs that have happened. We're obviously interested in seeing the health of our state and local budgets, healthy, and then also obviously the impact that it has on our individual members. We're particularly paying attention to concerns around access and quality. We've put our, a representative of our national union on the advisory committee for this. They're impressed by the thoroughness that the board has taken in placing its review. And really seeing this as a model potentially for the country. So we are here in full support of House Bill 424 and hope that we can expand this now so that all Marylanders can get the prescription drugs that they deserve. Thanks.
Thank you, Chair Pena-Melnick, Vice Chair Carlson, and members of the committee. My name is Lorraine Arikad. I'm the Senior Policy Analyst with 1199 SEIU, the largest healthcare workers union in the nation, where we represent over 10,000 healthcare workers across Maryland and DC, and over 400,000 across the East Coast. We strongly support HB 424 to expand the authority of the Prescription Drug Affordability Board. As healthcare workers, 1199 SEIU recognizes that prescriptions do little good if our patients cannot afford them. Some of our members have even sharing medications as they struggle with their own budgets, and about 6 in 10 adults say they're currently taking at least one prescription drug, and a quarter say they're currently taking 4 or more. Prescription drug prices increases places an unsustainable burden on our healthcare system, and the time to hold pharmaceutical companies accountable is now. What we have today is a healthcare system where pharmaceutical companies drive prices higher through their monopolistic market power, with the largest companies spending far more on advertising and on research. For those reasons and more, 1199 SEIU urges a favorable report from the Committee on HB 424.
Madam Chair, Madam Vice Chair, I'm the Reverend Ken Phelps from the Diocese of Maryland. It would make Vinnie DeMarco happy if I told you that I'm very proud to be here with many other faith leaders from the Lutheran Church, the Methodist Church, the Presbyterians, the Baltimore Jewish Council, so many of us who are behind this bill. And I will remind you, as I always do, that the Episcopal Church views health care as a human right. The bad news is I scrapped the rest of my testimony and decided I would play with ChatGPT, where I learned that the pharmaceutical and health industry spends approximately $233 million per year in lobbying efforts. In 2019, they spent $1 million in the state of Maryland to defeat the Prescription Drug Affordability Board, and since January, have already dumped another $500,000 here. You can relax, I asked, but it doesn't give me any names, so I can't tell you where exactly the money is going. So, sigh of relief. It bears, I've said this before in here too, and I want to quote the Reverend Mark Richards. I love the quote, but it's apropos, and it's good to be reminded of it every once in a while. He reminds us that when Jesus came to his capital, Jerusalem, the first thing he did was enter the temple and throw out all of the capitalists. Look it up, that's what he does, the money changers, those charging interest and what have you. I would add, 3 days later, it got him executed. But ever since then, Christians have been incredibly timid about taking on the power, right? We have looked into the eyes of corporate greed and blinked. In fact, we ourselves have even profited from us. But we have got to do something. I'm from a parish on the east side. I can't tell you how much money out of my discretionary fund has gone to paying for prescription drugs, helping people with their rent, with getting car repairs. The bottom is going to fall out if we don't begin to do something about this. Thank you.
I have a virtual witness, which I'm going to pull up, and then we'll open it up for questions, okay? Will you be so kind and bring the virtual witness? When we're done with this panel, we're going to go on to another unfavorable panel, okay? Just to be balanced. Will you be so kind and bring them up? And it's Danita Tolson. She has not arrived yet. All right, so we did call Danita Tolson. Okay, how about Carrington Anderson? Are you here? Will you be so kind and come up? Just pull a chair, please. Just take one of those chairs. No, right here, those chairs right there. Thank you. Good afternoon.
Thank you, Madam Chair and members of the committee. Carrington Anderson here with the Maryland Association of Counties, speaking in support of House Bill 424. I think the sponsor did a great job explaining the bill. This bill would allow PDAB to set a maximum price that a payer such as a local government can pay for a specific drug. Prescription drug prices, as we've talked about, are skyrocketing, and we're seeing this every year. We believe this bill will help county budgeting with drug price affordability. Benefits are expensive. Counties want to do right by their employees, and we believe that this bill will help. It's for these reasons that MACO would suggest a favorable report on House Bill 424.
Thank you. Thank you for the time. Look at that. All right, I'm going to open it up for questions now. Are there any questions from this panel? No questions. Thank you so much for coming. We really appreciate it. Next, we're going to go with an unfavorable panel. We have the first one, Aaliyah Horton, Kelly Schultz, Rainier Simmons, and I think they're virtual. If you could pull them up, please. Bridget Denderog Serrett and Amanda Boone. You see them? Excuse me? Okay. I'll call her in the next panel. Okay. Good afternoon, how are you? And I want to thank everyone for being patient as we get through these panels. I think we're doing okay with time, right? Being respectful, kind, and listening. And I thank you for being here. Who would like to get started?
Me too. Sure. I'll start, Madam Chair.
Thank you so much.
Good afternoon, Madam Chair, Madam Vice Chair, member of the committees. My name is Russell Polk. I'm the Director of State Government Affairs for the Southern and Mid-Atlantic regions for Biotech Innovation Organization, most commonly referred to as BIO. I am here in opposition of the House Bill 424 today. I'm going to cut my testimony short, basically, because it's already been reflective of the previous panel of my comments today, but our most concern was.
What is your name? What your name is?
Russell Polk, P-A-L-K.
Okay, I'm looking for it. Thank you.
I was in the first panel.
Yeah.
I didn't get to speak.
Okay, thank you.
Thank you, Madam Chair.
I just want to make sure the record reflects that you were here. Go
I
ahead.
understand.
Thank you.
Yes. Just real quickly, despite being years underway and having significant funding, not a single patient, which has been reflective in the testimony today, has benefited from the PDAB board so far, or expected to see any out-of-pocket cost savings as a result. That is because this bill would be expanding a flawed concept of price control that the current PDAB is attempting to implement in the form of upper payment limits. Setting upper payment limits will not lower the prescription drug costs for patients because they do not address out-of-pocket costs, which has already been reflective in the testimony as well. So I'll just close with this. As you can see, setting the upper payment limit will not trickle down savings to the patient at the pharmacy counter because almost all control over the final cost payments rests with their insurance and PBMs. For those reasons, BIO opposes House Bill 424 and urges an unfavorable report. Thank you, Madam Chair.
Next, how are you?
I am doing well, Madam Chair. How are you?
Good. It's great to see you.
It's great to be here. Thank you very much. For the record, my name is Kelly Schultz, and I'm the CEO of the Maryland Tech Council. I know all of you in this room, so I just want to say thank you for representing both sides of my board today with so much conversation about Prescription Drug Affordability Board and AI technology. So I can anticipate all of you to come to testify on the importance of AI and data centers and how we have to utilize energy in order to support all of them. But to the point at this moment, Madam Chair, Maryland, as we know, is one of the leading states in the nation for the concentration of life sciences companies, with 55,000 at least jobs that are created here each and every year. 2,700 life sciences and biotechnology companies, world-class universities and government agencies. Core to our mission is promoting policies that will continue to position Maryland as one of the top destinations in the country for innovation. We are concerned that the proposed expansion of the PDAB's authority runs counter to that goal and sends the wrong message to the life sciences industry. There are a few key points I want to highlight. UPLs have not been implemented in Maryland or any other state, so there is no data or evidence to support expansion. MTC continues to maintain that Maryland should not alter the PDAB's authority until UPLs or other policy actions are enacted and able to be comprehensively evaluated. This bill focuses solely on UPLs. Our member companies continue to urge a more holistic approach to examining all the factors that contribute to the price a patient pays for medication, including PBMs and health insurance practices. For example, MTC supports legislation that would reform practices around, we discussed it earlier, accumulator adjustment programs, which have an immediate impact on patient out-of-pocket costs. We urge consideration of the impact of expanding UPL's authority, and Maryland should be very proud of our ecosystem that we have created, and we would want to be able to continue to create a more vibrant ecosystem in this state because Maryland deserves it, Marylanders deserve it, and I think we deserve to see the state grow in that aspect. And for many of these reasons, Madam Chair, I urge an unfavorable report on this bill.
Thank you for your testimony today. Will you be next, please? How are you doing?
I'm doing well, doing well. Good afternoon, my name is Aaliyah Horton. I'm the Executive Director of the Maryland Pharmacists Association. We are the professional society of pharmacists, student pharmacists, and pharmacy technicians. I have submitted testimony for the record, and as you know, our pharmacists are the ones that are at the pharmacy counter with the patients that this bill is seeking to help. And we recognize those challenges. We work directly with the patients, trying to find the best way for them to access their medications in a way that they can afford them. With that said, pharmacies are challenged. And I heard a lot about if medications don't work, if people can't take them. They don't work if people don't have access to them either. And so the committee knows the challenges that pharmacies face with under reimbursements and little to no professional dispensing fees. And so when we as a community look at the upper payment limits and it's being defined as what the state can pay, there's no guarantee that the pharmacy can acquire the drug at the price the state can pay or that PBMs will reimburse the pharmacies for what they've paid. And that is a big concern. We don't want to continue having our pharmacies be the brunt of all of the changes that are seeking to take place higher up in the pharmaceutical chain. In addition to that, there were references to the system in Germany. And doing some research, and I'm happy to submit the report for the record that I have, I think we have to look at it holistically. In Germany, it's statutorily required that there is a pharmacy markup for the drug acquisition cost, as well as for the dispensing fee for whatever that negotiated rate is. And there are no PBMs, so it's difficult to translate what we've heard about that and put it here in Maryland, because we don't have that system, and our communities, our pharmacies are challenged. They are closing at an alarming rate, and we need to protect that. And if I could just make one comment, there were two medications. Okay, sorry.
Your time has expired, but I'm going to let you wrap your thoughts. As you know, the bills are due today. They're in the back right now. If any of you have bills, can you they're in the back, the clerk's room waiting for you. They did us a favor to come here. You can proceed and
Okay, just very quickly. I was reaching out to my members during the testimony, and I caught two medications that were mentioned. One was Farxiga, and one was Dupixent. Farxiga, right now, on average, the responses that I got are being reimbursed at under $200 at a deficit. So when pharmacies dispensing Farxiga, it's at a deficit. Dupixent is a specialty drug, and as we heard in the previous hearing, from the FTC report is showing that specialty drugs are being marked up by PBMs at about 1,000%. Our pharmacies, many of the community pharmacies, are not dispensing that medication. They're being steered to specialty pharmacies. And so there are a lot of issues that have to be addressed in order for pharmacies to stay open and provide the access and counseling to medication and medication services for patients. Thank you.
And I think, do we have a virtual unfavorable? Okay, so we're going to start with, let's just do, actually, let's do questions for this panel first, and then we'll do the virtual witnesses. So questions for this panel, please. Delegate Kipke.
Thank you, Madam Chairman. I guess this question might be for Bio, but whoever's best to answer it. You know, in the governor's State of the State, he acknowledged that Maryland has a real problem in our economy. Other states are cleaning our clock as it relates to enterprise, new jobs. Would you agree with me that the passage of this PDAB has already been a detriment to Maryland's economy, and that there is not the amount of new investment from the pharmaceutical community in our state, but there is new investment in other states, and this type of policy it risks making that worse, with a very unclear potential for benefit to the public good.
Yeah, I understand the question. We don't really know yet, because obviously if an upper payment limit is set and we are limited to the ability to, I guess, maximize what we can as far as the drug itself goes, I'm not sure I'm not saying we're not going to be investing in the state of Maryland. I just don't know yet because that's up to the individual companies. That's not up to bio, obviously, but I know biopharmaceutical companies are trying to invest in not only Maryland, but in all kinds of other countries. I will, to Kelly's point, to her point, there's over 50,000 jobs in the state of Maryland, which is significant compared to, for example, I was in Kentucky yesterday. They only have 17,000 biopharmaceutical jobs in that state. And so when I go from state to state, it varies from state to state, but that's obviously a company decision.
Any other questions?
Who is Delegate Shaliga?
Thank you.
Oh, you're welcome.
So for one of you best to be to answer this, again, well, I believe this bill is very well-intentioned, and I know the original bill was also well-intentioned, and the desire to bring down savings to patients at the pharmacy counter. I mean, that's what we'd like to see happen. So if a pharmaceutical company reduced their cost, do you think that would end up at the counter, at the pharmacy counter with the patient?
I'll answer no. The pharmacy benefit managers are in the middle and are manipulating how those drugs are being reimbursed, how they're getting onto formularies, all of that. And so I don't see it, and I'm not, a pharmaceutical economist, but the results of what we've seen over the last 20 years of how PBMs have impacted the supply chain, I feel pretty confident in saying that.
How do you think we can accomplish that? I mean, I know there's some other bills coming, but how can the pharmaceutical industry partner with us to get the common goal we have here is to reduce prices for people at the pharmacy counter?
Well, I think this is a great start, Delegate, because I think the conversation has to be ongoing. And as I travel from state to state, I want this committee to know that Maryland is being seen as a leader in this space. I think all parties need to be at the table moving forward, including PBMs and health insurance companies, because obviously this is a very, very complicated drug pricing is a very, very complicated thing. And right now, I think, it's being dominated by more people that are not in this room right now than we are, so.
Thank you.
Any other questions? Seeing none, thank you so much for your time, and thank you for being with us today, okay, for your testimony. We're going to go on to the favorable, virtual, and that is Rainier's, Simmons, Bridget, and Amanda. Will you please bring them up? And then Brandy and also Monique, let's just bring them all up. Yeah, we're gonna go back, thank you. And I'm sorry to the favorable, but we're gonna just, because I had said that I was gonna call them, so let's get started. Will you be so kind and get started, please? And also Monique, let's just bring them all up. Yeah, we're gonna Who's here? And I'm sorry to the favorable, but will you be so kind and turn off your speaker, please? And someone needs to get started. Brandy, can you unmute yourself, please?
Yes, thank you.
Or it says Brandy, but I don't know what what is your name?
My name is Brandy Chain. I'm with Pharmacists United for Truth and Transparency.
Okay. Yes, well, you could give us your testimony. Thank you so much.
Thank you. Thank you for the opportunity to speak today.
You're welcome.
Well, this bill aims to lower drug prices. It fails to address key issues that will devastate pharmacies and patients. Without addressing wholesaler pricing, administrative burdens, patient access, and reimbursement challenges, this bill risks doing more harm than good. It does not regulate wholesaler pricing, nor does it regulate PBM reimbursement. This bill has no infrastructure to ensure a pharmacy can purchase these drugs under the UPL. It does nothing to ensure that pharmacies are reimbursed fairly by PBM, meaning many will be forced to fill prescriptions at a loss. When pharmacies cannot sustain these financial losses, they are forced to reduce services, limit drug inventory, or close their doors altogether. Beyond financial strain, this bill adds new administrative burdens on pharmacies, including increased processing time and a longer procurement process if medications aren't available at the designated UPL. Community pharmacies already struggle with burdensome PBM complexities like prior authorizations and clawbacks. More red tape means less time for pharmacists to care for patients, further straining already overwhelmed healthcare providers. For patients, this bill does not directly lower out-of-pocket costs and may reduce access to essential medications. It does not control insurance copays, deductible costs, or premiums. If pharmacies close due to unsustainable pricing and reimbursement policies, patients, especially in rural and underserved areas, will have to travel further, wait longer, and may struggle to get the medications they need. A law designed to make medications more affordable should not make them harder to access. We all support efforts to lower drug prices, but this bill ignores the full picture. By failing to address these issues, it risks putting pharmacies out of business and leaving patients with fewer options, not more. We need real solutions that protect both affordability and access, because a lower price means nothing if the medication isn't there when a patient needs it.
Questions for this witness? Seeing none, thank you so much for being with us today and for your testimony. We really appreciate it, okay?
Thank you.
You're welcome. May we go next to Monique Whitney, please? She left? Okay, so how about Amanda Boone or Bridget or Rainier? All right, will you please go to Bridget? Will you please be so kind and you can start your testimony?
Hey, my name is Bridget Danderos-Arrett, and I am an autoimmune disease patient with severe genetic disorders, and I have been involved with Colorado's PDAP for the last 2 years. I'm testifying today because Colorado has realized it's made a very expensive mistake and that direct savings for patients is not going to happen. This costly mistake won't even most likely save money on premiums, and we now have a situation where an insurance company and PBM can say, oh, well, we were going to raise your premiums $50, but we're only going to raise it $48. And then that would be considered a win. The PDAP is a brainchild of a billionaire who has installed his own operatives on PDAP boards across the U.S., creating massive conflicts of interest with predetermined outcomes. We are all realizing that the short-sighted policy tries to exchange savings for assets. Drugs don't work if you can't access them. Operating under the myth that the formularies are chosen based on lowest cost is folly. It's based on the biggest rebates and profits. That means that a UPL makes a drug unfavorable for coverage, and formularies are going to be changed. A study commissioned by Partnership to Fight Chronic Disease confirms this, and not only that, but it will increase barriers to access, like fail-first therapy, more use of prior authorization, and non-medical switching. For a UPL to be successful, the manufacturer and the insurance companies have to sit there and say, we overcharged you, my bad, let's fix that. And somehow I'm very skeptical that's going to happen. No matter how you try to spin this, understand that PDAPs and UPLs put patients in danger and use us as pawns in the war against big health. I'm also a dual citizen of the UK and can't get my medicine there. I'm asking Maryland not to make the same mistake that we did in Colorado. There are significantly better tools that you can use to help us afford our medications. Thank you.
Thank you, and thank you for being with us. We really appreciate it, and thank you for sharing your personal experience, okay? We value it. Are there any questions for this witness? Seeing none, you have a blessed afternoon, okay? Thank you so much. Next, can we see if Amanda is back? No, how about Bridget?
That was Bridget.
Oh, that was Bridget. Rainier? All right, let's go with Rainier. Hi, how are you? Good afternoon.
Hello, good afternoon. Can you hear me okay?
Yes, we can.
Hi, good afternoon. My name is
Good
Rainier.
afternoon.
My name is Rainier Simons, and I'm speaking on behalf of the Community Access National Network in opposition of the bill. During a recent Maryland Finance Committee meeting with Director York, several problems were highlighted. Currently, there are no stipulations in place to guarantee formulary coverage of drugs selected for a UPL. Separate policies will need to be drafted for that protection. And as mentioned previously today, a UPL will not result in any pass-through savings directly to patients. Due to the nature of the state and local government plans, there is only the unknown possibility of potential cost savings to the state. Expanding board authority is unwise given the lack of understanding of the full effects on governmental plans when the commercial market is more complex with more risk of patient and system harm. Additionally, the board has no understanding of the effects of a UPL on the 340B program. A thorough analysis of the effects of 340B is not due in reporting to the General Assembly until 2026. No expansion of authority should be granted without a detailed understanding of the complexity of the 340B mechanisms and the safety net entities that depend on it. HB 24 also appears to remove the requirement of program monitoring. You cannot implement a program without monitoring the impacts. Proper monitoring is required to identify possible negative outcomes in patient access, health consequences of drug switching as a result of UPL, and the effects on the financial viability of an already fragile payer-provider ecosystem. Additionally, multiple sources of data show that a UPL will not result in any savings worth the risk of implementation. Notably, the Oregon Prescription Drug Advisory Board, through an independent consulting firm, discovered a UPL would have adverse effects on the state's Medicaid program and 340B safety net providers as a result of reduced rebate revenue, requiring additional appropriation to make programs and providers whole. The bottom line is there are currently no proof of concept. There are too many unanswered questions, no contingency plan to respond to unintended adverse effects on multiple levels, and the board continues to operate based on faulty reasoning, such as their current utilization of wholesale acquisition costs as a basis of drug selection. Expanding authority would only broaden the scope of potential damage that could be caused to patients and the state. Thank you.
With us and for being patient, are there any questions for this witness? Delegate Kaiser.
Thank you, Madam Chair. Thank you, Mr. Simons. I just wanted you to expand on the point you made about 340B drug pricing.
Yes, ma'am. I said the board does not currently have any good understanding of how UPL could affect the 340B program. The fact that the 340B program is dependent upon revenue rebates, and reducing UPLs can grossly affect that. It will lower their rebate, and so it would lower their revenues, which would lower the ability they have to fund their programs. And the board has not explored thoroughly how that will affect the 340B program and entities that depend on it in the state.
Okay, thank you.
Any other question? Seeing none, thank you for being with us. Is Monique back or here? Anyone waiting virtually? Okay, can you pull up the favorable, please? Thank you for being with us, sir. We really appreciate it. Next, we're going to go to, we have Danita Tolson, right? And then who else do I have? I have Paul Schwartz and Sandra Connor, and that should be it, right? No one else? Okay. Good afternoon, how are you? We can't hear you. Will you be so kind and speak up and come closer to the microphone?
Are you talking to me?
Yes,
Dr.
now,
Tolson?
yes, yeah, we can hear you now, Dr. Tolson.
Thank you.
Will you can get started, Dr. Tolson.
Thank you. Thank you for the opportunity to testify today in support of the House Bill 424, which would expand the upper payment limit authority of Maryland's Prescription Drug Affordability Board. Since 2018, the NAACP has been in support and been working to create support and strengthening our state prescription drug affordability board. We recognize the crucial role prescription drug costs and accessibility play in the health and well-being of our members and our communities. While we have been pleased to see the progress that the board has made in the past to address the cost for the state and the local governments, we know that more needs to be done to help the average Marylander struggling to afford these prescriptions. Expanding the authority of our Prescription Drug Affordability Board equips our state with the tools it needs to address the cost of the medications. While we are all hurting by the high cost of prescription drugs, our Black Marylanders are faced with the additional burdens to persistent racial health inequities. Black Americans are 60% likely to be diagnosed with diabetes than white Americans, and they are more than twice as likely to suffer from complications such as vision impairment, hyperlipidemia, hypertension, and end-stage renal disease. Despite this, a recent report revealed that more than 70% of semaglutide prescriptions, such as Ozempic, have gone to Caucasian patients. In addition to my role as an NACP health chairperson, I am also a nurse practitioner intern who has also saw firsthand how my patients have experienced high costs. In my practice, I have witnessed clients forego treatments of inability to pay. This has caused devastating impacts of healthcare outcomes, while the alternative of purchasing expensive medications, which can leave them in financial ruins. No Marylander should be forced to choose between their medications and other necessities. Thank you for the work this committee has done to improve healthcare access, affordability in this state thus far, and thank you to the lead sponsors. Maryland has been at the forefront of many issues and will need to continue to be a leader as we face unknown federal threats. We know that drugs don't work if people can afford them, so we respectfully request a favorable report of House Bill 424. Thank you.
Are there any questions for this witness? Okay, seeing none, thank you so much for being with us. Mr. Paul Schwartz, you can get started.
Thank you. My name is Paul Schwartz. I'm the National Region Vice President of the National Active and Retired Federal Employees, NARF. And I testify today in support of HB 424. Today, over $1 billion is spent monthly on pharmaceutical advertising. Jardiance is really swell, the little pill with the great big story to tell. However, as you well know, it wasn't primarily the pharmaceutical industry that caused the bill not to pass last year. It was the board's claim that they were not ready to take on the expanded authorities. They are now, or at least they tell us that. My main point, however, is that the cost of health care, especially the price of pharmaceuticals in America, is simply unaffordable for many Americans, including many Marylanders. There's even talk of repealing the Inflation Reduction Act, which included the $35 cap on insulin for those on Medicare, as well as Medicare's ability to negotiate pricing, which had been sought for decades until it finally passed in this legislation. Accordingly, it is going to be up to you, the people in this room, the state, to help Marylanders afford their health care and their prescription drugs. That is where the board comes in. Now, clearly, it's not a cure-all. Nothing is. But it's a big step in the right direction. They talked a lot today about moving out. Let me tell you something. If there's a profit to be made, and it's not up to the board to eliminate profit, they just want to make sure it's a fair market value. As long as there is a profit, those suppliers will stay in Maryland. I'm not concerned about that, right? So I'm going to leave you with two words as I come down to the 4-second mark. Martin Shkreli. Martin Shkreli should be in the back of everybody's mind why a board that provides oversight is so critical to keeping pricing down in Maryland so that we can afford to buy the pharmaceuticals we need. One last thing I'll tell you, I'm on Medicare, all right, and I get a statement, and it says my doctor charged $300. Medicare says they're only going to give him $100. You know how much I paid? $0. You know why? Because he took the $100, and he wasn't going to complain about it. And he's not leaving Maryland. He's not even leaving only Maryland. Thank you very much. Any questions?
Seeing none, thank you so much for sharing it with us, okay? We appreciate you. And the last witness of the day, will you be so, I'm sorry, for this bill, will you be so kind and unmute yourself for this bill?
I'm
This
gonna
is
cut
only
out
the
to go
first
up
bill,
to
by the way.
57, so thanks for the opportunity.
You're welcome. Go ahead, ma'am.
Hi, my name is Reverend Dr. Sandra Connor, and I'm the president of the Baptist Ministers Night Conference of Baltimore and vicinity. Thank you so very much for giving me this opportunity to be able to speak in favor of SHB 424. It gives me great pleasure to be a part of an awesome coalition that is consisting of faith leaders of multiple faith. Not only that, but all kinds of citizens have stood up to the test to say we want lower costs for prescription drugs. You've already heard the testimonies and the stories of what happens when people cannot get the drugs that they need. You already know the consequences of, if we don't do something, what could ultimately happen. I truly believe that healthcare is one of the issues that affects all the other social determinants of health. But my thing is, coming from a faith perspective, we believe that it is a moral obligation for us to make sure that everyone has an opportunity to have a good quality of life and an affordable quality of life at that. But we also believe that my Bible says that we ought to love thy neighbor. Who's your neighbors? All the people that you've heard about. You just heard Dr. Tolson said that the Black Americans, Black citizens of Maryland are suffering more so than others. But nonetheless, we're still all neighbors. Love is an action word. It says love thy neighbor. It's an action word. So if it's an action word, I encourage us to take action. I encourage us to support HB 424. I also ask that you take a good look inside your heart. And I ask that you think about it. What if this were you? Maybe you can afford the drugs now. Maybe your family can afford the drugs. But what about tomorrow? Everybody has an opportunity and don't know when they're going to fall on hard times. Let's take action. Let's do the right thing right now. Let's get the bill passed that the prescription drug affordability will have what they need so that all Marylanders will be able to experience low cost for prescription drugs. Thank you so very much for allowing me to speak on behalf of my organization and faith leaders.
Thank you, organization and the faith leaders. We appreciate it. Are there any questions for this witness? Seeing none, this was going to be the last witness. However, the one unfavorable we called, she was not here. She just came on. So I'm going to be fair and let her give the testimony, okay? Will you please pull the unfavorable? Have a great afternoon. Thank you so much.
Thank you.
And I believe this is Amanda Boom, and we had called her before. We're going to allow her to give it because she's here. She just left? Okay, so we're done. So this actually concludes the bill hearing on House Bill 424. We got through 30 witnesses. We still have a lot of work to do. We're going to take a 30-minute break for the committee. If you will be so kind and be at your seat, at 4:04, please. No later than that, that would be great. And for the weekly review, we're going to meet right now, please. Thank you so much. If you can bring us down temporarily. For those of you that are waiting for any bills that you have in this committee, we're taking a 30-minute break because we have to attend a meeting, but we'll be back at 4:04, okay? Delia Pruski, I'm sorry. This was a very long hearing since 1 o'clock, okay? Thank you. And anyone else that is waiting, we'll see you at 4:04. Thank you. can bring us live. I said 4:04, and it is 4:04, so your word is all you have, right? So we're going to get started. And again, thank you so much for being patient and for just waiting for us while we took care of something else. So we're going to start with Delegate Ruth, House Bill 417, Public Health Commission on Universal Health Care. Will you be so kind and come up with your panel? I believe you have Ken Phelps.
Should I start, Madam Chair?
Yes, please. Thank you so much.
Thank you, Madam Chair and Madam Vice Chair and members of the Health and Government Operations Committee. I just want to start by expressing my gratitude to this committee for all of your work over the years, trying to ensure that people can get health care when they need it, where they need it, and affordably. Maryland has been a leader in making sure that people have health care, including, I believe, the first in the nation Prescription Drug Affordability Board, which you just spent 2.5 hours, I think, talking about. But the reality is, because our situation is a patchwork of different insurance companies, different models, that it's hard to make sure everyone gets care, and it's expensive to do it that way. And so much of the work that you do is fixing broken parts of the system. But if we could roll back the system and create a new one that is simpler and would save money, that would be a huge benefit for Marylanders. And so this bill does not create a single-payer universal health care system. This bill is just a commission that studies it and looks into the complexities of it, because the fact is, a universal single-payer healthcare system would save the state money. I think many people recognize that that's true. And 25 years ago, in the year 2000, there was a report that was done by the Lewin Group, commissioned by the Maryland Citizens Health Initiative Education Fund. And that report said that a single-payer program would cover all Marylanders at a cost reduction of about $350 million a year. So 25 years ago, this report acknowledged that it would save money and cover all Marylanders. Now, not all was rosy in the report. There were some complexities that have to be overcome, which is why I think we need to look into it. One of the complexities is all the federal money that comes into the state, Medicare, Medicaid, federal employee health, all of that would have to be figured out. Although the way changes are going, we may end up seeing less federal money coming into the state. So, but while we have made tremendous progress in reducing the number of people who are uninsured, the reality is we still have problems. We have denials of care. We have people going into medical debt. We have long emergency room wait times, and I know somebody who was in the emergency room for, I think it was about 12 hours. So all of these things in one way or another. Oh, and we have pharmacy benefit managers, which I have to admit I do not understand what they are at all, except that they seem to make it more difficult to get your pharmaceuticals. So, and so if we could simplify the system, and it's not just patients. I've talked to many doctors who are frustrated that they spend hours on the phone with insurance companies trying to get their patients the care that they need. We shouldn't have a system that's based on denial. We should have a system that's based on ensuring everybody gets the health care that we need. So we know, I think many of us know it would save money, but we have to figure out how to get there. And so this bill is just a commission that would look into it. Now, admittedly, I still have a fiscal note on this bill, as I did last year. It's a little around $250,000. I know this year we have a high bar for fiscal notes, but the potential for saving the state money is huge if we can figure out how to make this work. So I'm happy to answer any questions, and I ask you to please find favorable for House Bill 417, and I forgot to say for the record, I'm Delegate Sheila Ruth.
Thank you, Delegate. Go ahead.
Madam Chair, Madam Vice Chair, Ken Phelps, still the Episcopal Diocese of Maryland. I would refer you to my written testimony, and in viewing that, you would realize that since 2009, the Episcopal Church, not just the Diocese of Maryland, has advocated for universal single-payer health care for the very reasons you gave, that this is something near and dear to our hearts. And we just, I guess it's a way of saying, you know, we have learned that the way we're doing it just does not work. What are we, 34th in the world in health outcomes? It's almost, you know, inexcusable to think that, you know, we cannot figure out how to take care of our people. I was going to give you another quote from MLK, one that came to mind, and it kind of got us into the weeds of budgets being moral documents, but I found a better one. Again, inspiration comes to you at the strangest of times. And what King said is this: faith is taking the first step, even when you can't see the whole staircase. And there are a lot of things to figure out with this, but we've tried the old way. What is the harm in trying a new way, taking this commission and exploring this, examining this, and seeing if it is possible through this to bring health care to all Marylanders? Again, as I've told you every time I speak on health bills, health care is a human right. Our church believes that. It teaches that. Let's try a new way.
For this witness, I have to tell you, Delegate, I really want to pass this bill, right? And it's a fiscal note. Can I task you with something?
I'll do my best.
Can you approach one of the university systems and see if they will be willing to do it, right? And have the same composition that you have here?
I would be glad to do that, Madam Chair, and if you have recommendations of particular universities, I'll be glad to talk offline about that.
Yeah, can you do that? Just,
Yes.
can you come and talk to the Vice Chair and I
will do
about
that.
this, okay?
I will do that. Thank you, Madam Chair.
Thank you. Anyone else has any questions? All right. Thank you very much for being here, both of you. We really appreciate you.
Thank you.
Okay. This actually concludes the bill hearing on House Bill 417. We're going to go next to, only because he is not on this committee, so we're going to give him the grace, and we're going to get out of order because he does have more witnesses, but we're going to do it. House Bill 459, Delegate Pruski, will you be so kind and come up? And can you bring your panel, please? And I believe you have on your panel, you have Jeffrey Bottle, Jamie McIntosh, Michael Gerard, and Robert Phillips.
Yes. Yeah, they're on their way, Madam Chair.
Okay, thank you. Good afternoon, how are you? And thank you for waiting.
I'm great. Thank you, Madam Chair. Peña-Melnick, Vice Chair Collison, and members of the committee. Good afternoon. For the record, my name is Delegate Pruski, and I'm here to testify on HB 459, Health Insurance Cancer Screening for Professional Firefighters, Required Coverage, James Jimmy Malone Act. This bill will require certain health insurers, nonprofit health service plans, and health maintenance organizations to provide coverage without the requirement for co-payment, co-insurance, or deductible to professional firefighters for cancer screening. In accordance with certain guidelines that require the Secretary of Budget and Management and certain counties and municipalities to ensure that certain employees' health benefit plans with coverage requirements for professional firefighters. Firefighters partake in jobs that are high risk. Firefighters face many risks. That includes exposures to toxic chemicals, heat, and smoke, as well as physical injuries. Unfortunately, in Maryland, we've lost men and women because they were trying to do their job. Cancer also is one of those causes, and occupation cancer is real. HB 459 focuses on the dangerous, unknown, and known exposure of these toxic chemicals, heat, and smoke. Too many firefighters have gotten cancer because of their profession, and one of them is one of our former members. Some of you may have recognized Delegate Jimmy Malone, who served in the House of Delegates, recently passed away in December from cancer. I can't do justice to go through Delegate Malone's record, but for those of you that knew him, he was a lieutenant in the Baltimore County Fire Department. He was a lifetime member of the Arbutus Volunteer Fire Department, among many others. But the one thing you can say, and many people said this, You're never alone without Jimmy Malone. Jimmy served and made sure he was an advocate for highway safety and state emergency medical system. He was a true public servant. And that's why I'm honored today to bring this bill in memory of him. And let us honor his memory and his service. I want to take a moment to recognize, I know his family came yesterday for the Senate hearing, but I want to recognize his wife and I want to thank her. I want to thank her for coming yesterday. I know today, because of the hearing, she could not, but I also want to thank his daughter for coming yesterday. Cancer screening can make a difference. Medical practice and research over the past few years have been innovative in detecting early signs of cancer through blood work and testing. This is crucial in making a difference in someone's life. Not only is the right thing to do, it can save a life and even save resources and reverse the progression of costlier treatment if you catch it early. Today, you will hear directly from fellow Marylanders and those that serve and the citizens in the firefighter profession. They will tell you about the difference. And I want to thank you, Delegate Malone, for your service. We appreciate you not only as a delegate, but as a firefighter. And this bill reflects your true memory. And I did not have the pleasure of serving with Jimmy, but I will tell you, his legacy lives on throughout the Maryland General Assembly. And I ask you, Madam Chair, and this committee for a favorable report for HB 459 for health insurance for cancer screening for our professional firefighters. Thank you.
Thank you very much for your testimony. I served with former Delegate Jimmy Malone, and he was a beautiful human being. He was a gem. So, next, please.
Good afternoon, Madam Chairs. My name is Jeff Buttle, President of the Professional Firefighters of Maryland. We represent approximately 10,000 active and retired fire and EMS personnel across the state of Maryland. Let me talk for a minute about my good friend Jimmy Malone, who was a close personal friend and colleague. He is missed dearly and remembered fondly. Jimmy was a champion for the fire service in which he cared about very deeply his brothers and sisters across the state of Maryland. He served many years as a delegate in the halls of the Maryland General Assembly and in this House of Delegates, an institution that he loved being a part of. Sadly, Jimmy passed away of cancer in December of this past year. I can't help to think maybe if we had this type of program in place when Jimmy started in the fire service, that we could have identified the cancer sooner and treated it in the early stages. Firefighters work in a high-risk profession. We accept the risks every time we go out the door of a fire station on an emergency response. However, the single greatest risk we face as firefighters is occupational cancer. It is literally killing our members. This legislation will provide meaningful access to early cancer screening when cancer is highly treatable and has the best chance of success in sending it into remission. Legislators always ask us, how can we help the firefighters? Well, you can pass this bill, because if you do, it will provide an impact for generations of firefighters to come. It is also fitting that having this bill named after my friend and colleague Jimmy Malone will in many ways allow him to continue to look over his brother and sister firefighters, just like he always did and just like he always will. What an outstanding way to honor his legacy while at the same time protecting our firefighters across the state of Maryland. Thank you very much.
My name's Teresa Crispin. I put in for oral testimony for Chief Phillips. I'm the assistant, or actually, I'm the vice chairman of the Maryland State Firefighters Association's Legislative Committee. And Jimmy actually sat as the vice chairman with myself for several years after he left the legislature. We stand in support of this bill. We find it very, very important. I rode an ambulance when I started at the age of 16, and I rode till the age of 43. So that's 27 years of my life that I gave to the fire service in the aspects of an EMS provider. In 2010, I was diagnosed with cancer. It still sits in my head. It sits on my hard palate. There's no treatment for me, and having this precursor would actually help. Not knowing what would it be, I know what Jimmy would tell me to do right now, say me too. So in all of support, we as a fire service wholeheartedly stand behind the professionals to ensure that this bill gets passed. Thank you.
I'm sorry for your loss, okay? He was blessed to have a friend like you. Thank you so much.
Thank you.
We're going to open it up for questions now. I know that Delegate Morgan has the first question.
Madam Chair.
My pleasure.
And thank you for the bill, Delegate, and sorry for your loss. I do want to ask you a question with the bill, the way it's written in the fiscal note. It says professional firefighter means an individual employed as a firefighter by the state, county, or municipality during the time of the individual employment. So this would only apply to paid firefighters and not volunteers.
That's correct. The current,
That's correct.
Current aspect, yeah.
If you were a county employee or paid firefighter by the state, county, or municipality, wouldn't you be on their insurance plan? Or have access through employer-based insurance?
As far as like an HMO or other things like that?
Or anything, like it might be a...
Yeah, I mean, again, we're basing the bill based upon the code and defining a professional firefighter. I know, again, because the Senate hearing, the volunteers are not included. If you look at the larger counties, I don't know if Jeff wants to add on whoever else, but I know that, again, just defining who would be covered and who would not.
Yeah, I think it depends on the county you're talking about. Most of the larger jurisdictions, the answer is yes. The firefighters do have insurance through the employer, whoever's employing them. I think it depends on the county you're talking about of what type of insurance they have. So if you're looking at the larger
because most counties are
self-insured, and
yeah,
some of the smaller
right.
Counties have more of a traditional insurance product to offer their employees.
Thank you. Thank you, Madam Chair.
Yeah.
Any other questions? Have you spoken to the League of Life Insurance, to Masha and Tilano?
I have not.
Okay. How about the Maryland Insurance Administration?
Yes, they have comments in the bill. And also MACO mentioned here that has minimal impact. I mean, obviously I'll let them testify themselves, but MML also had some information shared as well. And I just want to reiterate what Mr. Buttle said, that some counties kind of have this in their contract, and it depends on what's included in their benefits program. So some are already doing it. So it just depends on who, which agency. But the intention of the bill is to make sure it's all covered. We want to save a life. That's our whole intent for this.
Okay. So we have, I definitely would love to pass the bill, and we have, as you know, the fiscal situation this session, and it says that from the MIA, the state will be required to defray the cost of the new mandate to the extent it applied to individual and small group ACA plans. If you could meet with them to try to figure out what that is, the amount, because I have to let appropriations know. And if you can meet with Masha and Tilano as well. And if you don't have their information, when you leave here, the Vice Chair can step aside and give you their numbers. Is that okay?
Absolutely.
Yeah, because we all love Jimmy and we want to do it. I just want to make sure that we have cross our T's and dot our I's. Any questions? Thank you so much. Good job. Thank you. Next, we're going to go on to Jamie McIntosh, Michael Gerard, Robert Phillips, it's okay. Who would like to get started?
I'll go first. Good afternoon, Chair Pena-Milnick, Vice Chair Collison, members of the committee. For the record, my name is Jamie McIntosh, and I'm here representing myself and over 900 members of the Anne Arundel County Professional Firefighters. I'm speaking in support of House Bill 459, and I want to thank Delegate Pruski for sponsoring that important bill. I'm a professional firefighter who has occupational cancer. When I began my career, nobody was talking about the increased risk of cancer to firefighters. That was 32 years ago. In 2017, although it wasn't guaranteed at the time, I was lucky enough to have been the beneficiary of early testing, which found anomalies in my blood values. After several months of further testing, those abnormal values were ultimately determined to be caused by hairy cell leukemia. Early screening not only allowed me to receive treatment earlier in the progression of my disease, but also protected me while I was working before my treatment began. It's difficult for me to think about what might have happened if my cancer had not been discovered early. My white blood count was low. My absolute neutrophil count, or ANC, was low. My platelet levels were low. Low white blood counts and low ANC cause decreased immune response when exposed to disease. As a professional firefighter, I'm constantly exposed to diseases on emergency medical incidents. If I had not known about my decreased blood counts, I could have easily contracted a normally benign disease that could have caused serious illness or even death. Platelets are the substances in the blood that promote clotting. With a decreased platelet level, I was at risk for significant bleeding from a small cut. It would have been even worse if I had had a serious injury at work which required emergency surgery. Early screening provided me with the best opportunity to remain healthy and continue my career serving the residents of Anne Arundel County as a professional firefighter. Unfortunately, many cancers do not have early markers in blood tests. Some require ultrasound or other types of scans, which aren't covered by insurance. Every method of early screening should be available to firefighters in order to give them the best chance to discover and treat cancer at its earliest stages. This is not only the right thing to do because firefighters are at a higher risk of cancer, but it's also the financially responsible thing to do. Early detection means less invasive and less costly treatments are available. Early screening saves lives, careers, and money. For these reasons, I respectfully urge the committee to issue a favorable report for the House Bill 459.
I want to thank you on behalf of the committee for sharing your personal story, and I'm so glad you're doing well and that you're here. And I know Jimmy's smiling right now. Thank you. He had a beautiful smile. He will light up a room. Thank you, okay? Next, please.
Good afternoon, Madam Chair and Madam Vice Chair. My name is Michael Gerard. I'm a retired lieutenant from the Anne Arundel County Fire Department. I, too, have had experience now 2 times at the young age of 56 with cancer. One, being misdiagnosed early. They had to make an incision in me that looked like a medical glove box. Had I been caught earlier, it would have been a simple procedure. Last year, I wasn't feeling right on my own. I went to a place, had blood work done to find out I have prostate cancer. It's because I found it out early. I am gifted, really, that I have everything that's available to treat it right now. I have, whether it be active surveillance, radical prostatectomy, external beam radiation, or brachytherapy. Had I not went and had this done, I'd be sitting here today, not even knowing that I have it. One of the things, Jamie talked about years ago, the fire service, I'd never worried, never even thought of cancer. Everything was our heart. Firemen die of heart attacks. So I too knew Jimmy Malone. One of my best buddies was just his pallbearer, who I will see this evening. So in honor of him, I wanted to be here today to testify, to tell my story.
Thank you for sharing this story, and I'm also so glad that they caught it early.
Thank you.
You're making a difference.
Thank you.
You're welcome. I'm going to open it up for questions. Are there any questions for this panel? Seeing none, thank you so much. Okay?
Thank you.
Have
Thank
a
you for your
blessed
time.
day. You're welcome. There was one other person I called, Robert Phillips.
I spoke for him.
Okay, you spoke for him. Okay, great. And you did an amazing job. You tell him that. We have Carrington Anderson. And good afternoon again.
Good afternoon. Thank you, Madam Chair and members of the committee. My name is Carrington Anderson with the Maryland Association of Counties, speaking in support with amendments on House Bill 459. First, I want to thank the sponsor for bringing this bill. MACO is completely in support of the intent of this bill and all it does for our career firefighters who sacrifice so much for our local communities. Our only issue with this bill, and just again, I want to say our only issue is the fiscal implications. I want to share that every county who has career firefighters has an existing cancer screening program. It might not look exactly how this bill prescribes. It looks a little bit different in every county. Many counties depend on a grant to make this work with their budget capacity. But this bill requires no cost sharing, no deductible, no co-payment, and we get that. We think it's a meritorious idea, but counties who are impacted by this estimate a $1 million fiscal impact to comply with this. And if this is a priority of the state, which it is entirely within your all's authority to say so, MAKO's amendment would suggest that the state sets aside money and make this a funded mandate. Counties cannot absorb this cost. Counties are trying to pay for the blueprint, and additionally, 2/3 of Marylanders live in a county where they already impose the maximum income tax rate. I understand that the state is in a difficult financial and fiscal situation, but so are counties. I also just want to point out that Delegate Kaiser has a bill, House Bill 757. It's the Professional Volunteer Firefighter Cancer Bill for the screening technology program. This adds increased funding, and we think this is a great bill, another great approach to do something great for our firefighters for both the career and the volunteer. So MAKO will also be supporting that bill, and just think it's a wonderful bill, and I believe it'll go through this committee, so I hope the committee also supports that bill. For these reasons, MAKO requests a favorable with amendment report on House Bill 459. Thank you.
Thank you. Any questions for this witness? Seeing none, can I ask you, will you be so kind and meet with the sponsor of the bill?
Thank you I will be happy to.
Yeah, that would be great. And so that you can sort of show what's out there. And maybe if you're already doing something, maybe that can become the law, and then that would be existing resources, right? Because you're already doing it. If you could just sit down with him and talk about it, I really would appreciate it. All right? And
Thank you,
he's
Madam
right
Chair.
there in the back. If you can exchange your cell phone, that would be great. All right? I believe that this was actually the last witness for this bill. This will conclude the bill's hearing on House Bill 459. Delegate Pruski. Yeah, Delegate Pruski, if you could go around and come here for a second. Thank you. This concludes the bill hearing on House Bill 459. We are now going to go to Delegate Hutchinson. Thank you for being patient. And that is House Bill 565, State Board of Pharmacy Renewal Notices, Electronic Means. And can you bring do you have a panel?
She's no longer here. I'll do this all by myself tonight.
All right. You're good. You're more than good enough.
I think I can handle this one. Thank you, Madam Chair.
You're welcome.
I also noticed, though, Madam Chair, it's 4:30. We've gone through 4 bills, and House Bill 424 actually had 2 sponsors. So we get 2 dinners, I think, out of that.
Actually, yes. Everyone vote for me.
So, good afternoon. I'm here to present House Bill 565, State Board of Pharmacy Renewal Notice, Electronic Means. It was brought to me by the board to sponsor this bill. I know there's no such thing as an easy bill, but this is probably as close as we can get to an easy bill. We've had other bills like this in the committee before. This is simply going to allow the board to send their renewal notices electronically through email. This is going to streamline their operations. It's going to reduce their mail and printing costs and postage costs. They're going to save about $14,500 a year by doing this. They send out about 40,000 renewals a year. And if somebody does want to opt out of it and still get it done by mail, they simply can do this. So we've done this for many other boards, and we're just asking for this for the Board of Pharmacy, and I ask for your favorable vote on this bill.
Thank you. Easy testimony. Any questions for the delegate? All right, are you guys ready to vote it? No, just kidding. Okay, this actually will conclude the bill hearing on House Bill 565. Next, we have House Bill 666, Delegate Woods. Maryland Medical Assistance Program and Health Insurance require coverage for calcium score testing. Delegate Woods, and also if you will bring the other file for House Bill 665, we'll do them. All right, beautiful. Let's do, and let's see, do you have a panel? If they can come up, Florence Champagne and Ruth Harris. Thank you so much. And ladies, thank you for waiting. I know I've seen you here all afternoon, and everyone else is waiting. Thank you. You can get started.
Good afternoon.
Madam Chair, Madam Vice Chair, members of this esteemed Health and Government Operations Committee, I am Delegate Jamila Woods, very proud member of this committee and humbly honored to serve with you. I'm here to request a favorable response for HB 666, Maryland Medical Assistance Program and Health Insurance required coverage for calcium score testing. The U.S. Center for Disease Control and Prevention report that an American dies from heart disease every 33 seconds. I want you to let that sink in for a moment. There are several risk factors for heart disease, including diabetes, high blood pressure, high cholesterol, and a family history of premature coronary artery disease. Calcium score testing is an evidence-based predictor, strong predictor of cardiovascular events. Calcium score testing, I'm sorry, let me get this correct. Coronary artery calcium, or CAC, is a strong predictor of cardiovascular events. Calcium score testing is an evidence-based priority test to determine risk for cardiovascular disease, reportedly outperforming other risk assessments in predicting the risk of future cardiovascular occurrences and death. It is cost-effective in people with no active coronary symptoms and helps patients better understand and receive the appropriate support to improve their health outcomes. Currently, heart disease is the #1 cause of death in the state of Maryland. With 1 in 5 deaths, that's 20% of residents having died in 2021 as a direct result of coronary artery disease. This bill, like so many others brought before this esteemed body, is presented before you once again this year with an emphasis on the urgency of now. This year, required coverage for calcium score testing has been made a legislative priority by the Legislative Black Caucus of Maryland in consideration of the fact that African Americans are disproportionately impacted by cardiovascular disease. And as a point of self-disclosure, as an African American woman, I am currently medicated for high blood pressure, diabetes, and high cholesterol. This bill is personal and of particular interest to me because I also have a brother 1 year apart in age who, like me, has 3 of the 4 identified risk factors for heart disease and has already suffered from 3 heart attacks. While learning my biological history, having not had knowledge of it for the first 60 years of my life, having grown up in foster care, adopted at 12 years old, I recently learned of my biological family members, my biological father included, who died as a result of heart-related challenges in 2017. According to the CDC, if you have a family history of heart disease, you are more likely to develop heart disease yourself because different types of heart disease and related conditions like high blood pressure and high cholesterol can run in the family, and it clearly does in mine. My desire is not only that we pass this bill in Maryland, but that we serve as a role model for other states to join in the effort to assure that we make the best possible health outcome options equitably available to our constituents as it relates to heart health. Calcium score testing is a covered service for the Maryland Medical Assistance Program. However, there are insurers, nonprofit health plans, HMOs, and managed care organizations who do not provide the coverage despite patients having at least 3 of the significant risk factors. This bill merely emphasizes the value for persons who have 3 out of 4 telltale risk factors: high blood pressure, diabetes, high cholesterol, and/or a premature family history of coronary artery disease. They can receive coverage for calcium score tests that can greatly reduce subsequent medical costs significantly by putting the corrective measures in place proactively. We have support from organizations like the State of Maryland Advisory Council on Health and Wellness, RadNet, who leads the nation in outpatient diagnostic imaging services, and Dr. Underwood, who testified last year. Dr. Paul Underwood, the Vice Chair of Open My Heart Foundation, the Chair-elect of the Association of Black Cardiologists, and the President of Cardio MedSci LLC. Dr. Underwood says the Maryland Department of Health Vital Statistics reported in 2021 that more than 12,000 of the 58,000 deaths, again 20% that year, were due to heart disease. He goes on to say that fatal heart attack victims have no symptoms until minutes before they die, hence early detection of high-risk asymptomatic individuals as needed. In 2020, a similar bill was passed in Texas, HB 1290, and after 6 years of follow-up showed an associated reduction in reported cardiovascular disease. He says preventable heart attacks are killing Americans who are not adequately aware of their risk. The current standard of care not only fails to alert high-risk individuals, but also results in potentially unnecessary drug therapy for low-risk individuals. Early detection of high-risk asymptomatic individuals with CAC testing presents a low-hanging fruit. For that reason, Madam Chair, Vice Chair, and members of this Health and Government Operations Committee, I request your favorable support of House Bill 666. Thank you. I don't know that I like the 666 so much. Butter up.
It's okay. It's being delivered by someone of faith.
Thank you.
Okay. Who's next?
Okay. My name is Florence Champagne. I am the CEO and founder of the Open My Heart Foundation. I am a heart attack survivor. And I'm here supporting me today are Sisters for Sisters Network. I am here to support House Bill 666. As a result of my heart attack, I had to have emergency open heart surgery. Leading up to that, I did not readily receive the proper diagnostic screenings. I was even told by a cardiologist that I did not receive the proper diagnostic screening due to my lack of insurance coverage at that time. He said, "Don't worry, we'll find a way to get you the proper diagnostic testing." I was asymptomatic, but I did have the risk factors of high blood pressure, diabetes, and family history. And heart attacks ran in my family. I am here to urge you to support House Bill 666, a simple calcium score test paid for by insurance providers for early detection of cardiac issues, which could possibly save a life like mine. Therefore, I urge you to favorably support House Bill 666. Thank you.
Thank you. Thank you for sharing your story, and I'm so delighted to see it.
Thank you.
Yes, my name is Ruth Harris, and I am a heart attack survivor also. I'm here to support the House Bill 666. I was an active person, a vegetarian for over 55 years, and I was a caregiver for my husband for over 10 years. I had no signs or symptoms. I didn't have a family history. I did have a family history of heart disease. My heart attack could have been avoided if I'd had an early screening, such as a calcium score test. Therefore, I'm here to support HB 666 so that insurance providers can pay for this simple screening, which could possibly save lives. I'm here also to be the voice of those who have no voice. Thank you for hearing my story.
Thank you. Thank you, Madam Chair. I think I'm good. I was going to make the 666 joke, and Delegate Woods already did. So thank you, Pastor Woods.
My pleasure.
I noticed that the Department of Health testified in writing favorable with amendments.
That's correct, Madam Chair, and we are in support of those amendments to include those who have an autoimmune disease and who smoke. We also learned that there's very minimal increase of any fiscal note, that it's not significant as it is a very low percentage of persons who would be included.
And the League of Life and Health Insurers, it's unfavorable. Have you had conversations with them?
I have not and would like to have that conversation and get further
So if you
information.
can speak to Matt Shanti.
My friend Matt.
He's a friend, you have to quote Shanti Martinez, friend of
Yes,
Shanti Martinez.
our friend.
Yes.
In absentia, our friend.
Yeah. Sounds good, Delegate. Great testimony. Who else has a?
Kind of covered it, but I'll just do it quickly anyhow.
Yeah.
Because I read MedChi's note, and they had a suggestion about adding more risk factors. So I was curious if you were in discussion with them or were happy that that was a favorable amendment idea.
Yes, that's what I was talking about, the autoimmune disease and the risk factor for persons who smoke. We are willing to accept that amendment.
Okay, thank you so much. I don't see any other questions, Delegate. Excellent job. Thank you both. And ma'am, thank you for sharing your story as well, and I'm so glad you're here with us. Okay? You have a wonderful, blessed day, and this concludes the bill hearing on the House Bill number that will not be named. And how about if we go to House Bill 665, Delegate Woods, Maryland Medical Assistance Program and Health Insurance, Annual Behavioral Health Wellness Visit, Coverage and Reimbursement. If you'll be so kind and come out with NCCOG. And if you can also bring up Letitia Christensen, she's virtual? She's not there? Okay.
It got too late for her.
Okay.
Okay.
Clients.
Okay. They say she's not virtual, so you can get started, Delegate.
Thank you again, Madam Chair, Madam Vice Chair, and members of this distinguished Health and Government Operations Committee. House Bill 665 requires Medicaid and commercial carriers to provide health coverage and reimbursement for annual behavioral health wellness visits from a trained behavioral health clinician whose scope of practice includes the provision of mental health and substance use disorder services. These services, provided by a trained mental health clinician, are not the same as an extremely limited screening provided by a primary care provider, making those limited mental health inquiries at the same time they are screening for somatic illnesses. This full biosocial psychological evaluation is conducted by the trained mental health clinician and provides a clinically relevant diagnosis where applicable. It should be noted that House Bill 665 is essential to eliminating the stigma surrounding mental health and mental illness. Presently, a patient who seeks to be assessed by a primary care physician or behavioral health provider must be diagnosed with a mental illness for their insurance to cover the cost. And interestingly, that initial diagnosis made by a physician not trained to provide a clinical diagnosis may not be accurate, or the resulting diagnosis, if any, provided by a trained mental health clinician to whom the patient has been referred may never exist. Nevertheless, that initial diagnosis inappropriately follows that patient. The outcome is not the same for somatic health care providers like your primary care physicians, dentists, optometrists, gynecologists, and more. My doctor should not diagnose me with cancer before an appropriate screening has been made. That should be done by a trained specialist, and he should not have to give me a diagnosis to be compensated for his services. I'm talking about a primary care physician. Currently, a primary care physician can provide a routine checkup with no actual condition that rises to the level of a formal diagnosis. Insurance covers the cost, and providers are reimbursed for the service. This is not true, however, for behavioral health care. And this really should be addressed as an ethical issue for both primary care physicians and for therapists as it relates to healthcare uniformity, as physical and mental health both fall equally under the umbrella of health, and both are duty-bound to require accurate and specific assessments to assure the appropriate preventative care, health care needs of patients are met. Current law excludes behavioral health providers from offering appropriately addressed preventative health care as a routine service without first providing an initial diagnosis. This law should exclude a primary care physician from diagnosing a behavioral health condition without completion of a full biopsychosocial evaluation. I reiterate my concerns that this is an ethical issue because no one should be permitted to provide a premature or otherwise inaccurate diagnosis in order to be reimbursed for their services. The Maryland Healthcare Commission, the Maryland Healthcare Commission, commissioned a study in 2023. My tang is all tangled up. The Maryland Healthcare Commission commissioned a study in 2023 to determine the cost of annual behavioral health wellness visits from a behavioral health provider in the commercial market. That study found the mandate is expected to increase premiums by just 37 cents per member, lost my place, per month. They predict a 2% annual increase in the percentage of patients receiving treatment because of the mandate and medical savings of 2.5% of total costs for each new patient. This bill enhances and advances how we approach behavioral health in Maryland. It has the potential to limit ED wait times for psychiatric care and fosters an appropriate gateway to behavioral health services. Annual behavioral health visits, as identified in this legislation, provide immeasurable encouragement in efforts to destigmatize the interaction between clinician and patient and increases the ability to identify behavioral healthcare issues where applicable early and effectuate preventative mental care healthcare options to avoid more costly services in the future. For this reason, I am asking a favorable response for House Bill 665. Thank you.
Thank you, Delegate, and thank you for getting that letter, which is important.
Thank you.
I have to step out on Thursdays. I have a standing meeting with the judiciary regarding the lack of bed issue that we have. So we have a whole group, informal work group, and I have to go and do that now. But my very capable vice chair will stay here, okay?
You could just move the bill.
I like this woman right here.
We're nice, but we're not that nice.
I know. Thank you. Thank you, Madam Chair, members of the committee. My name is Ann Seacott, and I am testifying today both on behalf of the Maryland chapter of the National Association of Social Workers and the National Council on Alcoholism and Drug Dependence. And the one witness representing NASW just had a limited window, and she had to go see some patients. So we are in strong support of House Bill 665, very appreciative of Delegate Woods' support. I want to just make 4 points. I just want to clarify, because I think sometimes people read this bill and just misunderstand some of the intent. This is about prevention. This is just like how we are all encouraged to go see for free at no cost. The insurance is mandated to see us for a physical every year to make sure we're okay. And if we're fine and there's nothing wrong, we still want to get that visit, and that provider still gets paid for that visit. That's what we want to equate to behavioral health. And we want people to be able to have access. They already have the access to their primary care provider. This would say you can have access to a social worker, to a licensed professional counselor, and get this assessment that is about your substance use or your mental health. And it's about maybe identifying something very early in its stages and be given ideas on how you might be able to cope and manage some of your feelings, some of your symptoms, and be able to prevent something worse happening down the road. Perhaps it's just giving you peace of mind that, no, the way you're feeling is totally normal given the circumstances. So you're not depressed or, reaching some level of clinical diagnosis. I also want to emphasize this is not screening. We all get that screening when we're at our primary care provider visit. It's a few questions. It might be a few minutes. That's wonderful. And there's nothing in this bill that prevents that primary care provider from making a referral to a specialty provider if they think that there's something wrong and follow-up needs to happen. This is an assessment that takes almost an hour, and it has to be done by a licensed clinician. I will close just by saying we don't believe that this splits sort of body and mind. We believe this is another avenue, and it will really help people avoid some of the stigma that is associated with being scared to tell your primary care provider about something. Here's someone that you can speak to and really find out are you heading down a bad direction and need some help, or no, what you're experiencing is very normal. And thank you, Delegate. Are there questions for the delegate or her panel? Delegate Hill.
Thank you, Madam Chair, and thank you, Delegate, for this bill. I just need some clarity. I've had complaints for a number of years, concerns. As has been stated by Ms. Seacott, screenings are done by the primary care physician, fine. But what I hear from behavioral health specialists is that while no one has a problem with the fact that the majority of behavioral health treatment is done through primary care physicians, there has been an increased problem where primary care physicians are continuing to treat psychiatric problems that they should not be treating. And that they are often mistreating it with the wrong diagnosis. They continue to do so and just change medications. And it takes a long time for those people to be referred to proper behavioral health specialists to get the right diagnosis and the right treatment on board. And more problematic is that people with complex problems are delayed in getting the treatment they need. Would this help address that problem? Is it a problem that you're also aware of?
It is definitely a problem that we're aware of, and yes, to have that biopsychosocial evaluation that Ann spoke of, that takes about an hour, that gets your complete history, would make a big difference in being able to accurately define and understand what a person should be diagnosed with and how they should be treated.
And would you expect then that there would be a change in how primary care is treated? In other words, the patient would then come back to them with a proper diagnosis, and if appropriate, they might, in consultation with the professional behavioral health specialist, psychiatrist, what have you, be able to still be the primary manager.
Absolutely.
But they wouldn't be outside of their specialty and doing the management.
Absolutely, because it shouldn't be either or. It can be a both and interaction that would be a win-win for that patient.
Delegate Bagno?
Madam Chair, and I think you just answered my question, but I just want to make sure that I've got it accurately. So this still works in collaboration with the collaborative care model, with our existing models. This is not a replacement. This is in addition to another access point.
Yes, this is an enhancement to make sure, because for too long, we've separated them, right? We've separated mental from physical health, and the truth is they all are one part of that compact, if you will. And so, yes, this is not saying we want to separate anything, but we want to bring the services together to make sure that we have more coordinated care in a more uniform manner.
Thank you. Thank you, Madam Chair.
Thank you.
Okay. Seeing no other questions, I do want to ask, and I truly appreciate your intent here. It's right on, especially given the increased need for behavioral health services, but we have a real shortage of providers. And folks are having a hard time getting into a behavioral health provider already. And there are, we're dealing with, I think, a bill that's, redefining the distance and the time, and with respect to participating in a network, not participating in a network. So how do you think this kind of mandate would affect that, or a person would be affected ultimately by this kind of mandate, given that shortage?
I'm going to defer to Ann.
So that's a very, good question, and two responses. And one is, this is not a mandate that everybody do it, right? So there will probably be, unfortunately, probably not enough people who will take advantage of this. So this is not a requirement that everybody that has insurance. We don't do that with our our annual wellness physicals, right? So nobody's monitoring this to see. This is here for those who may want it. So I think the report says a 2% increase. I need to go back and clarify that to look at that. So we're not talking about everybody doing it. So it's not like all of a sudden all of us now need more access to behavioral health providers. So my second response is, you all are doing a lot of work to try to address that workforce shortage. You keep passing bills to try to do that. You just today at a subcommittee, thank you all very much, passed a social worker compact bill. You've created compacts and other good incentives related to increasing that workforce. And so, maybe by the time people really pick up on this as a benefit and really want to take care of it, address it, take advantage of it, it. Maybe we've done something to really improve the condition of the workforce.
Okay, great, thank you. Delegate Hill?
If I may.
It better be only one.
Just the one. To the chair's point, if behavioral health specialists are actually getting paid to do these assessments, might that mean that there's more availability to have the assessments done? Because previously, they're not being covered, which is why you have the bill. So there's a shortage of providers, but there's also a shortage of providers because they're not getting paid for the services that they provide. Am I wrong or hitting on that?
So providers are getting paid for the services they provide. It's if someone comes to, let's say, a social worker and says, I'm feeling really depressed and, down, and I've lost someone I love, and, I don't know if I'm dealing with like official, clinically definable depression, or I'm just normal sad. And so for that social worker to spend that time, do that assessment, and maybe it is just a normal sad, you're not depressed, all that, that social worker has choices. One, say to that person, and of course, this discussion happens ahead of time, not after the fact. If you don't have a diagnosis, I can't bill your insurance. And so are you okay with me giving you a diagnosis, even if it's sort of like a grief disorder, something really kind of low level? And, or you can pay out of pocket. And so that member gets to decide whether they, want to have a diagnosis. Going in, they know they have to get one for that provider to get paid, or pay out of pocket or walk away. So it's about, I think it's about a much more healthy therapeutic relationship between the therapist and the client, because it won't have to be sort of a forced thing just in order to get paid.
Delegate Hutchinson.
Thank you, Madam Vice Chair. I just want to note that Delegate Hill just started asking questions only after the chair left the room tonight.
No further questions. Thank you very much for your testimony for the bill, Delegate. I'm going to actually call a favorable with amendment. Alyssa Glickstein? Glickstein.
Vice Chair Cullison and members of the committee, thank you for the opportunity to provide testimony in favor of House Bill 665 with an amendment. My name is Alyssa Glickstein, and I'm a policy associate at Children's National Hospital, and we provide a comprehensive range of behavioral health services for Maryland children and youth. Children's National Hospital is in strong support of HB 665. Physical health annual wellness visits are a routine finance component of our healthcare systems, and behavioral health care should be the same, and HB 665 is a strong component in advancing behavioral health parity. Providing annual preventative behavioral health checkups for children, adolescents, and adults offers the same benefits for both providers and patients. Routine behavioral health visits build structure and predictability into provider schedules, allowing for appropriate screening protocols, staffing, and specialization. Preventive and early intervention measures, especially beginning in childhood and adolescence, have been proven to reduce incidence of severe mental illness later in life. Further, every dollar spent on mental health prevention and early identification of youth behavioral health disorders can save $2 to $10 on local and state education, juvenile justice, and healthcare costs. Therefore, financing preventive approaches for children and adolescents can lead to millions of dollars in savings for the state of Maryland. We strongly believe that, when enacted, HB 665 will provide a strong preventive element to Maryland's continuum of behavioral health care and will reduce the occurrence of serious mental illness across the state. While we urge the passage of HB 665, Children's National suggests that the committee amend the legislation to explicitly state that coverage is included for children and adolescents ages 0 to 21. I applaud Delegate Woods for introducing this important legislation, which will have lifelong benefits for our state's youngest residents and their families, and respectfully request a favorable report with the proposed amendment on House Bill 665. Thank you for the opportunity to give testimony, and I am happy to respond to any questions you may have.
Thank you. Are there questions from the committee? Okay, Seeing no one, I think you just about covered it. Thank you very much for being here and your patience today. So now the unfavorable panel. I'd like to call up Kimberly Robinson and everyone's friend, Matt Celentano. Kim, you're everyone's friend too. Don't take it personally.
Thank you. Thank you, Madam Chair.
Can I go first?
Yes.
Okay. Good afternoon, Madam Chair, members of the committee. Matt Celentano here today on behalf of the League of Life and Health Insurers in opposition to House Bill 665. Conceptually, we're very much supportive of this effort, as we obviously want beneficiaries to access behavioral health. And in a lot of ways, we believe this is already happening. It's our understanding, actually, that the Department of Health has said that the MCOs are already in compliance with how this bill is drafted. Medicare beneficiaries have a screening incorporated into their primary care visits, and Marylanders going to their no-cost annual wellness visits are already being screened for behavioral health challenges, and if identified, are referred to a specialist. We've spoken for many years about removing the stigma around behavioral health, and to separate the screening in this legislation we think is a step backwards. Your primary care visit should cover your whole self. This concern was especially raised by the Maryland healthcare commissioners when they reviewed this, and multiple commissioners when they reviewed or discussed this bill in the interim before last, where they had the analysis of the prior bill. And there was great hesitancy to recommend moving forward with this legislation on the subject. I mean, I will say from the insurer's point of view, we have issues getting folks to go to their annual behavioral health, or their regular wellness check, let alone getting to go to a separate one. So incorporating a significant check on your behavioral health at that point, we think is really important. Our other hesitancy on this bill, as the committee obviously knows, is that we have a tremendous behavioral health shortage. We saw a Maryland Matters article just this past December that said we are 30,000 providers short to be able to cover the behavioral health needs. That is a tremendous, tremendous challenge. I mean, I know this committee is working very hard on it, and so is the General Assembly, but it is a factor that we really need to consider. We don't want an influx of patients looking for an annual visit, and we can't provide that opportunity. So to further reason, the framework for the behavioral health visit that's outlined in this bill is already happening. We would suggest we continue on that course, and we urge an unfavorable report.
Thank you, Madam Chair, members of the committee. Kimberly Robinson on behalf of Blue Cross, Care First Blue Cross Blue Shield. I'm also here respectfully in opposition to House Bill 665. I won't repeat all the things that Mr. Celentano said, but I will just highlight a couple of points. One of the concerns that our team who manages behavioral health services and our provider network raised, one was certainly the shortage issue that he just referenced, but in particular is also the concern of pushing away from allowing primary care providers to have that expected interaction with their patients. As he mentioned, we have a hard time getting people just to see a PCP once a year. There are so many Marylanders, even who have access to an annual visit that is in fact at no cost under the ACA, who don't take advantage of that. So when we have them there and their PCP is able to have that conversation, to do the screening questions that has been incorporated into their scope of work, that is intended to check in about substance use and how we're feeling and things we're experiencing and what is our anxiety and our stress level and what sort of things we've encountered in our lives, it makes sure that someone has the opportunity to flag that and now can do a warm handoff to a behavioral health provider. The way the bill is structured, it only allows this to be done by a licensed behavioral health specialist. They're super important to the network, but if we leave all of that to happen outside of that first check, and I know some will say, well, they can still do the check, so we'll have them, we'll reimburse them for the check and then we'll reimburse for something separate. We want to make sure that people are able to access this as best they can. We want to make sure we're using all of our touch points. We certainly are sensitive to some of the issues and concerns that the proponents have raised. And so I have taken that feedback back inside of the company and I'm talking to my medical director who works in this particular space. He's a behavioral health professional himself. And so we are hoping to find some creative solutions to find some place in between where we are and where the bill is. And we'll certainly come back to the committee. But as of this moment, we urge an unfavorable report.
Okay. I'm looking. Delegate Woods, you had a question?
Yes, thank you so much for your presentation. My question is this. when a person goes to a primary care physician and they talk about certain symptoms, if that primary care physician is not clinically trained to address that issue, that primary care physician automatically refers them. With behavioral health concerns, do you not agree that a primary care physician asks extremely limited questions that completely could brush over any serious mental health concerns or conditions that that person has?
I'm happy to go.
Sure.
So, Delegate Woods, is this the portion of the program where I get my ChatGPT answer, or do I keep going?
You know what? Because you're my friend, Matt, you can use the chat.
No, I mean, I think there's a couple of ways to sort of address that. I think that primary care physicians are trained to establish sort of red flags and to try to properly refer to the appropriate provider. I would also suggest that, as stated earlier, there is a very limited primary care check. I don't believe that actually to be the case. When I just went for my wellness check a couple of months ago, which my wife had to make me go to, which doesn't seem that abnormal, I had to fill out a pretty extensive written survey before I actually got into the back room that was pretty significant, with about 20 questions or so. And then the doctor asked me a bunch of questions. It was not 3. There was everything around gambling, alcohol, if I had a gun in the home, sad, feelings of depression. It was a pretty extensive thing, a pretty extensive list. So I think that there is a growing sort of movement within the primary care space that this is an important part of your entire whole self, right? There is literature from the American Psychological Association that has sort of a best practice a set of questions for primary care physicians to use, and we hope that maybe we could talk about with the boards, making sure that that checklist is incorporated, but having a separate appointment, we don't think is the appropriate way to go forward.
Madam Chair, may I have a follow-up?
Yes.
Are you aware of the number of somatic challenges that people who visit their primary care physician are not addressed because those physical ailments are also directly related to behavioral health?
I do not know that number, Delegate Woods.
Are you aware of that is a challenge?
It does not surprise me, but that's not something that I dug into when looking into this bill.
Thank you.
Okay. Okay. Delegate Hill.
I thought about not asking the question, but since you called on me.
And your light was flashing.
So you just said that the 20-question screening that your primary care does, I want to make sure I heard you, you equate that to a behavioral health evaluation where you sit down and you focus on more than those questions, but actually it's almost the reverse, where you talk about your somatic symptoms and see if they're behavioral health causes and other things. You're saying those are equivalent, the primary care screen?
No. I'm saying that on my intake forms, there were specific questions that were related to behavioral health. That was just a part of it.
Right.
And then there were specific questions that was asked orally by the doctor later, but it wasn't just as simple as it was sort of presented here as that 3 questions and that was it. It was way more intensive than that.
And then let me just ask this question. When your primary care looks at your EKG and makes a determination that they think it has some slight abnormality or that it's normal, do you consider that to be carry the same weight as your cardiologist looking at that EKG? If you had the EKG and your primary care said it's fine and you were having symptoms, wouldn't you want the cardiologist?
For sure, and I think that if there was a flag, I think that you would be referred to a specialist, a behavioral health specialist, if there was something that was a concern.
And if they missed it, this is the opportunity for be caught, because often the people doing the screening don't have the specialty to catch the diagnosis. Thank you, I appreciate it.
Okay. Seeing no further questions, thank you both very much for your patience and for responding to us today. We have a virtual witness. She is not there. Okay, so then that concludes the hearing on House Bill 665. Thank you very much, Delegate, for the bill. And we are going to go to House Bill 429, which I promise is going to be shorter than the first one I did. I am actually going to sit up here since I need to have access to the room. But but I would like my panel to come to the table. This is House Bill 429. I am the sponsor. Delegate Cullison, Health Facilities Delegation of Inspection Authority, Nursing Homes. I have Janice Zalen, Dixie Butler, Tammy Bresnahan, Linda Bergovsky, and is Earl in the room? Earl Stoddard? Ah. So I will get started. And, you know, you all heard this bill last year. What it does is it addresses the lack of inspections of nursing home facilities that are needed to keep our residents safe and comfortable in their living facilities by allowing, but not requiring, local governments to conduct those inspections. It was introduced last year. We withdrew, Senator Kramer and I withdrew the bill in favor of meeting with the Department of Health over the intersession to try to resolve the issues we had. Senator Kramer and I met several times with members of MDH, and the result was, in December, MDH agreed to engage in a memorandum of understanding with Montgomery County to do the annual surveys, but at full cost. They did not agree to a cost-sharing arrangement, which had been the case in the previous MOU, which was in place for almost 20 years, but ended in 2020. And the county had been requesting from the Department of Health reinstatement of that MOU beginning in 21 and was continually denied. The reason for the bill today is that we believe the state should at least share equally in the cost. Not only have they not agreed to the cost sharing, but they've stated that additional staff would be needed at the state level to monitor the behavior of the local. The county has requested renewal of the original MOU and has been, but that has been declined. Annual inspections of nursing homes is required by the Centers for Medicaid and Medicare Services. But the Office of Healthcare Quality, which is responsible for these surveys and charged with monitoring the quality of care in nursing homes, as well as a lot of other healthcare facilities and community-based programs, on behalf of CMS, they are rarely staffed at a level that allows them to do all of the surveys necessary. I would say they were never staffed. They did, in our discussions over this year, OHCQ added a significant number of positions to do the surveys, and they worked with a consultant to handle some major complaints. But it's my understanding that those surveyors will not be certified to be able to do the surveys for at least 2 years. So when we did this before in Montgomery County, we had actually staff at Montgomery County who were doing those inspections. They had a team of surveys that include nurses and nurse administrators. They were employed at that time by County Department of Health and Human Services. The state supported the cost of these staff by 60%. This bill, we're asking for 50%. As a result, in Montgomery County, for the entire duration of the time of the MOU, every single one of the 34 nursing homes in Montgomery County got an annual survey. So now, since then, since 22, when their MOU is no longer in place, in 22, one nursing home in Montgomery County was surveyed. In 23, 0. According to CMS, this is data right from their website, 90% of the county's nursing homes have not received the annual inspection in the last 15 months. In fact, in that data, it shows that in most of the counties in our state, less than 50% have had the annual surveys completed. In Caroline and Talbot County, 0 compliance. So the fiscal note is a bit of a puzzlement to me. because these annual surveys are a requirement. But it says that there's a cost to this, that the cost of the state would be indeterminate because of the need to hire additional staff to oversee the counties who are choosing to share in the cost of the inspections. It seems pretty unlikely to me because, first of all, we did it before without this level of staffing. And secondly, now there's a decrease on the demands of the other staff at OHCQ who would be available to do some of this oversight as needed. There's also a section in the fiscal note that says that there would be an increase in the cost of the surveys. And we know that these surveys are split with federal money, and we know that they get somewhere between $3 and $4 million a year to do the surveys as the federal split. But the program isn't funded by the number of surveys done. Like when you're in a fee-for-service model and you go to the doctor, and then the Medicare pays for 50% of that visit. That's not the case in this model. They're paying for staff, so to do the surveys. And again, the state would only be paying 50% of the cost. There's a section in the fiscal note that speaks to local effect, fiscal effect. Of course, there is. Montgomery County, in this instance, is offering to pay 50% of the cost of the staff that it would take to annually inspect our nursing homes. They do that by choice. This bill is requested by our county. The agreement is, and just to be clear, the bill is an enabling legislation for any county that chose to do this, but no county would be mandated to do it. The agreement would be a win-win-win. Win for residents, a win for local governments who request this authority, and a win for the state, who's going to save, in my estimation, save some expertise in their own providers. So, and the backlog of surveys could be addressed more quickly. So with that, I am going to humbly request a favorable report of this bill and call on my panel. I will let you choose who goes first.
I win.
Okay.
Good afternoon, Vice Chair Cullison and esteemed members of the committee. My name is Linda Bergovsky. Thank you for the opportunity to present this testimony in support of HB 429, Health Facilities Delegation of Inspection Authority, Nursing Homes. And special thanks to Delegate Cullison for sponsoring this bill. I am here today as co-chair of the Montgomery County Commission on Aging. The commission is authorized by the Older Americans Act, PL 116-131, and was established by Montgomery County in 1974 to advise county government on the needs, interests, and issues of concern to its older residents and to advocate on their behalf at the local, state, and national levels. State surveyors, as you have heard, are required to conduct health and safety inspections of nursing homes for compliance with Medicare and Medicaid regulations. These usually happen once a year. I am here today supporting HB 429 because 31 of the 34 nursing homes in Montgomery County have not been inspected in at least 2 years. Those 31 facilities are home to over 3,600 residents. They are our parents, our grandparents, our friends, our neighbors. They are vulnerable individuals who need assistance with most activities of daily living. They are not experts on nursing home quality. The Commission believes that these valued residents of our community deserve far more attention to their well-being than they are currently receiving from the state. OHCQ has had exclusive responsibility for periodic inspections of nursing homes in Montgomery County since the beginning of FY22. The state declined to renew the MOU, as you've heard. The information, the 31 out of 34 not getting inspected, that's from CMS data. You couldn't find that data on OHCQ's website. I am here requesting a favorable report on 429, HB 429, because our residents deserve better. They deserve our attention. They deserve timely inspections. Thank you, and I'm available for any questions.
Thank you. Who would like to go next? Okay.
Good afternoon. Can you hear me okay?
Yes.
Okay. My name is Janice Zalin. I'm testifying as a private citizen with a strong background on this subject of oversight for nursing facilities. I worked in a trade association that represents nursing facilities for 15 years. Upon retirement, I was a certified long-term care ombudsman volunteer for 8 years. I have been involved with nursing facilities professionally and as a volunteer for enough years to understand the importance of government oversight to ensure that residents of nursing facilities are cared for properly. These individuals are the state's most vulnerable citizens. Government oversight that ensures that residents are in a safe environment and receiving care that meets regulatory standards is absolutely crucial. That's why the federal mandate requires states to conduct annual inspections and to conduct complaint investigations. And yet, for reasons that are incomprehensible to me, the state of Maryland fails to abide by this federal mandate and thus is endangering its residents of nursing facilities. HB 429 would allow the state to delegate its nursing home inspection authority to county government, or county government. And I would want to stress that we are talking about Montgomery County a lot, but this is for any county that would want to do this in the state. And the state did delegate its responsibilities to Montgomery County for at least 10 years, during which time the county performed admirably. I know this because I was a long-term care ombudsman during that time. I saw the county surveyors conduct annual inspections. I saw the nursing facility improve when the county surveyors cited deficiencies. I saw the quality of life and the quality of care improve for the residents after a survey. I also saw county surveyors diligently conduct on-site complaint investigations. Also important, when I was aware of a serious problem, the nursing facility administrator would work with me for a solution because they did not want the issue to rise to the level of a complaint to state government or to county government, to any government. Today, there's no such motivation as the state doesn't follow up on complaints. And I will conclude by saying I respectfully urge this committee to return a favorable report on HB 429. Thank you.
Thank you. Next.
Hello. May I be the first one to say good evening?
Yes.
My name is Dixie Butler, and I am a long-term resident of Montgomery County, Maryland, District 19, and I am here in support of HB 429. Do you know how to identify a quality nursing home for a loved one? Well, an annual survey of nursing homes covering health and safety and complaint investigations are to be conducted by the Office of Healthcare Quality. In the past year, I have learned that these required activities have been delayed for months and years. Previously, these functions were delegated to Montgomery County by an MOU. That has since expired. It is time to place these critically important responsibilities back in county hands. It is with a sense of urgency that I support this legislation. I am here as a concerned older citizen, family member, a licensed social worker, a volunteer long-term care ombudsman. Timely surveys of nursing home health and safety conditions as required by law are essential. They represent the guardrails and safeguards needed to sustain trust, quality, and safety. What can happen when these actions are delayed? Residents and families are left to challenge facility conditions, such as inadequate staffing, poor food quality, safety hazards, neglect, and worse. As someone once said to me, that's not really a fair fight. It is a joy to see when nursing home residents have a safe and caring environment, because this is not always the case. Timely surveys and complaint follow-up that are proactive and preventive are our responsibility. Health and lives are at stake. The passage of HB 429 will help restore support for Montgomery County nursing home residents, the trust of families, and the standard of care. I respectfully urge this committee to return a favorable report on HB 429.
Thank you. Good afternoon, Madam Chair and members of the Health and Government Operations Committee. I'm Tammy Bresnahan. I'm the Senior Director of Advocacy for AARP Maryland. We are here in strong support of House Bill 429. Long-term care has been on our radar screen for a number of years. We've been before your committee many times in the nursing home and assisted living area. These folks from Montgomery County contacted me. They call themselves the Tiger Team, and we've been meeting for about 6 months every Wednesday to talk about this bill, and I can't tell you how concerned they've been. This bill will help the state, will help them do their job, and we only see it as a win-win. We think that anything that the county can do to help them make sure that nursing homes are inspected is good. As of June 23rd, Maryland had the nation's second highest backlog of overdue annual nursing home inspections, with over 80% of homes delayed by at least 17 months. Alarming, 104 facilities out of 222 had not been inspected for more than 4 years. These are the people that live in your communities. We ask you for a favorable report. Thank you.
Thank you. And Dr. Stoddard, you are actually from the County Executive's Office, is that correct?
Correct.
Thank you.
Good evening, Vice Chair Cullison, members of the Health and Government Operations Committee. My name is Earl Stoddard. I'm an Assistant Chief Administrative Officer in Montgomery County, and I'm here today testifying on behalf of County Executive Mark Elrich in favor of House Bill 429. Montgomery County shares the desire of everyone in this committee to ensure that nursing homes and other long-term care facilities in the state of Maryland are safe and healthy for our aging residents. As Vice Chair Cullison alluded to in her opening, for many years Montgomery County worked under an MOU with the state of Maryland through the Maryland Department of Health to conduct those nursing home surveys to ensure that our nursing homes met CMS standards. In 2020, the Maryland Department of Health ended the MOU with Montgomery County. But at the time of the ending of that MOU, Montgomery County was regularly completing its Tier 1 surveys and actually proceeding into Tier 2 through 4, which include off-hour surveys as well as complaint-based surveys with regularity. While progress has been made, not all of the Tier 1 surveys in 2024 have been completed statewide, according to the most recent CMS reporting, and the state will not proceed into Tier 2 through Tier 4, which includes those off-hours and complaint-based reviews until after they've completed all the Tier 1 surveys, which obviously could take quite some time. Montgomery County stands ready to support the state of Maryland in meeting its responsibilities. We strongly believe that our county and perhaps others would be willing to serve as a force multiplier that assists the state in meeting its statutory responsibility for all state jurisdictions statewide. To that end, and frankly to their credit, Secretary Herrera-Scott and Deputy Secretary Kalyana Rama asked for a meeting in November where they expressed a willingness to re-enter into the MOU. Those MOU discussions remain ongoing with the state and Montgomery County. County Executive Elrich is prepared to seek local funding to support a fair share of the costs associated with supporting these facility surveys in Montgomery County. And we request that the committee provide a favorable report on House Bill 429 to establish an ongoing process for counties to work collaboratively with the state to protect our vulnerable seniors. Thank you.
Thank you. Questions for this panel? Okay, this is,
Yeah,
Delegate Bandari.
Yeah, this is a very good bill, but did you see the opposition letter from Maryland Health Department?
Could you repeat the question?
MDH is in opposition of this bill. Have you seen that? Do you have any comment on that bill? Basically, they say that it's a great idea, but the enforcement mechanism would be better if the state does it than the local county. That's their opposition.
Well, they're in ongoing MOU discussions with us, which means that they're in favor of the county taking a role in this. What they seem to be in opposition to is the cost share associated with it. But as Vice Chair Cullison alluded to, the state receives somewhere between $3 and $4 million a year. And in our view, let's say hypothetically they gave $500,000 to Montgomery County to do this, we'd be putting in $500,000 ourselves. So you'd take, let's say, $3.5 million, and you'd be turning into $4 million of actual value for this because the county would be itself putting in that match effectively. And so we view it as money well spent. It's not actually, again, the state is receiving money from the federal government to do this activity. If they gave a portion of that to Montgomery County, we'd match it with county dollars, and you get more service for the same dollars being offered to the state from the federal government.
That makes sense. Thank you.
Any other questions? Oh,
May I add, actually, that's a really good point I wanted to add too. And so if Montgomery County takes on this role, it actually allows them to defray other surveyors to around the other parts of the state. And so we would effectively be taking on a responsibility in Montgomery County that would allow them to focus more resources in the other counties that are not meeting the standard or are worse than Montgomery County in some cases.
okay, thank you all very much. Thank you for staying here. I think you've been here all afternoon, so I really appreciate your time and your testimony today. I am going to call Carrington Anderson. And Dana Kaufman, would you come on up to the table too, please? And Carrington, I'm going to ask you to go first since you are favorable.
Thank you, Madam Vice Chair, members of the committee. Carrington Anderson with the Maryland Association of Counties, speaking in support of House Bill 429. You have my written testimony, so I'll be brief. And the Vice Chair did a great job in the panel kind of explaining the bill and the situation here. MACO believes this bill is in the spirit of collaboration between the state and local government. We know that everyone, including the state and local government, have been experiencing serious workforce challenges. We believe this bill will help us collaborate and help protect some of our most vulnerable, especially for counties that feel like they are able and willing to step up and fill this gap. For these reasons, MACO would ask a favorable report on House Bill 429.
Great, thank you very much. And Dana Kaufman, you have a favorable with amendment.
Yes. Vice Chair Cullison, members of the committee, for the record, my name is Dana Kaufman. I'm here on behalf of Lifespan Network. And we are in support of this bill with amendments. I know it's probably easy for you to think that the nursing homes don't want to be surveyed, but when we do not have surveys or when those surveys are delayed, they do have a domino effect on our operations. Not only do they impact quality of care for the residents, and Lifespan has always been a very strong supporter of enforcement actions, but when we don't have surveyors coming in for 4 years, what happens is, one, they're in there for about 3 weeks, and two, they are looking at records that go back 4 or 5 years. And half the time lately, the nursing homes that were subject of 4 or 5 years ago don't even own them now. So we're being cited for violations where the resident is no longer there, the staff is no longer there, the nursing home doesn't own it anymore. And depending on what the tag is for that deficiency can cause Medicare admissions to be limited, or for our workforce challenges, can even result in our geriatric nursing assistance programs being taken offline, which helps no one because we need staff desperately. So we do support this bill. When I first started,
Go ahead.
we support. I was going to say, when I first started representing nursing homes back like 20 years ago, you could be clockwork on the surveys. They were done every year. You could almost put it on your calendar. So it can be done. We just need to get back to it. The amendments are clarifying. We just want to tighten some of the language and make sure that the intent is what it is. And I'm working with both sponsors on it. So thank you very much.
Thank you very much. Questions for this panel? Seeing none, I look forward to working with you on it. So we have an unfavorable panel from the Maryland Department of Health, Dr. Kalyanarama. Good evening.
Good evening, Vice Chair Collison and members of this committee. For the record, I'm Dr. Nilesh Kalyanaraman, the Deputy Secretary for Public Health at the Maryland Department of Health, and I am here to speak in opposition to House Bill 429. Just want to start by acknowledging, yes, I've been here before this committee and others in the legislature to acknowledge the backlogs that OHCQ has faced, and we have been working diligently to recover from that, and we've been making tremendous progress on that. So I just want to put that out there that this is, I'm not telling you that our performance is good, but I am telling you that our performance has been increasing steadily over the past year, and we're doing much better. That said, this bill I don't think is well situated to actually solve the problem that we have. You've heard here that we've been in discussions with Montgomery County. That's true, I know, because I've been reaching out over 8 times in the past year and have been the one reaching out. And frankly, we've been ready to negotiate with Montgomery County, but their offer of putting money in is contingent on us giving it. And that's the issue, which is that as we are recovering, as we are getting our survey activity back to where it should be, pulling money out from the department does not help. It does not help us in doing our work. And we, as the delegated authority by CMS, we can't abrogate our responsibility anywhere in the county. Acknowledging that we fell down, we are picking ourselves up. It is an important need. But we can't just say, Montgomery County, you do whatever you want. Because if they fall behind, we're still responsible. And if they're caught up, those dollars, they don't help us to, when they're carved out, they don't help us to move faster elsewhere in the county because they're the same dollars we would have used to survey Montgomery County, right? And so this is really, I think, a bill that would hamper our ability to manage this at the state level. I just want to note that I understand that the data on CMS shows where we are. If I may, for a moment, I just want to share that that CMS data is completion data. We have started, with your indulgence, just a few more seconds. Our annual surveys are now up to 109, which is almost 50%. Yes. Those will be completed in the next few months by CMS because they have to go through a review process, but we've made tremendous progress. In Montgomery County, we've been to 10 of the LTCs in the past 7 months, and we have, I would say, without giving up too much because we can't announce surveys, we will be in the majority of them in the next majority of the ones that have not been surveyed in the next 6 months. So I just want to impress upon the fact that we are ready to negotiate, but we don't want to compromise the state's ability to be able to do this work equitably as we're recovering. And so for that reason, I ask that you return an unfavorable report on this bill.
Thank you. Questions for Dr. Kaye? I see Delegate Hutchinson.
Thank you, Madam Vice Chair. I was confused about how you just said that was going to be paid for because in the bill it says the department and the county shall equally share the cost of conducting site visits and full surveys delegated by the secretary. I read that, isn't that a savings to the department that half of it's being paid for by the county?
Well, not as we read it, right? Because this is an additional investment by Montgomery County. I mean, 50%. We are putting in our portion that is pro rata Montgomery County. The county has the opportunity right now to invest dollars. We've already agreed to that. There's no barrier to that, other than the fact that they've said that they don't have the funds to do it.
But I'm sorry, but I read that as if it costs $1,000 to do, I'm just making a number, $1,000, that if it costs the state $1,000, that it's not going to cost the state $500.
That's not how we read it, and I'm happy to get clarification on what's being proposed here, but that's not how we've read it.
Okay, thank you.
Thank you. Delegate Gazzoni.
Thank you, Madam Vice Chair. I'm sort of in the same ballpark as Delegate Hutchinson because I'm fairly sure that what was shared earlier was that for a number of years, in the ballpark of 20, I think, MDH was paying 60% of the salaries of the folks in Montgomery County, so therefore Montgomery County would be covering 40%. So now Montgomery County appears to be saying, we'll pay up to 50%. So it strikes me that you're just leaving money on the table.
With due
Because they're
respect,
giving you money.
they've
do
been
this.
welcome to give us money, but they haven't done so yet. And that
Okay, but
we
you're
don't
not
need a
letting them
bill
do,
to do
you're
that.
not letting them do the surveys yet. Is that, am I misunderstanding?
Say it again?
They're not actually doing the surveys yet for you.
They are not doing surveys, no.
Okay, so they're not giving you money yet because they're not doing the surveys yet. They're paying their people to do this. Maybe I'm completely misunderstanding.
So they do not have any staff right now, nor could they, because we would have to delegate that authority. We
Sure,
have the
but that was
federal
done
state-
before.
That was done before, and we have repeatedly said that we're open to figuring out a way to do this and to be able to delegate some of this authority to them. But that said, they would have to, we can't delegate that until they have staff and funds to be able to do that.
Okay, I'm still a little bit confused but that's okay. I understand that point. I'm just not sure where the county stands on that because that was not something that was addressed during their presentation, but that's.
Okay. Thank you, Delegate. Delegate Kaiser?
Excuse me. Thank you, Madam Chair. I was taking a look at the fiscal note, and I wanted to understand the reference about the OHCQ monitoring the counties, and if the workload of current staff is then reduced by the engagement of local governments, why would that require more staff?
So we do need to have staff to oversee the work that they're doing. We are still.
But more staff. I mean, wouldn't there be a reduction of staff not doing certain things, even if there's then some increase of staff monitoring? I don't understand why it would need to be an equal number of the monitoring of those who used to do.
Understood. So what gets a little tricky there is that it's the hypothetical, right? Which is that we are going to, in our budget, we have to assume that it's flat. And so we still have the positions. And so we would need additional. Of course, if this bill passed and we were giving Montgomery County the money, we would have fewer positions to be able to fund. But we would need positions to oversee, coordinate, and scheduling. So any federal or state activities, we can't wash our hands of it. We have to still be engaged in it. We still have to oversee it, and we still have to make sure that it matches the quality that we deliver throughout the state. So there's we can't just zero out our investment in Montgomery County and say, you do it, we're not gonna look at it, we're not gonna do anything with it.
Madam Chair, can I ask another question?
Yes.
I just want to follow up, but if there's a current number of staff that are doing the work now, and I understand you just said you can't zero them out, but could you not do that in the next budget go-round? And save money long-term?
It's not saving money in that sense, right? Like the money is just going to a different entity.
Well, if 5 people used to do the work and only 2 have to monitor, I'd like to think that that would be a nice cost savings unless there's different math going on.
Well, but remember that money is then going to Montgomery County, that's going to us, and now we're giving it to Montgomery County. So the dollars don't go down, it's just who's controlling the dollars changes. And so yes, MDH wouldn't have those dollars, we'd be contracting it.
I'll follow up later, thank you.
Thank you. Delegate Bandari and then Delegate Bagno.
Oh, thank you, Madam Vice Chair. I read the letter by Department of Health. Looks very fantastic in concept. Yeah, definitely if there is a consistent regulatory oversight is good. Then when the county head, it might be fragmented, additional administrative burden, everything is good, right? But in the meantime, you accept that OSCQ has acknowledged a backlog of survey. Do you accept that?
Absolutely.
And the complaint, right? Then if you do accept that, how does the department justify opposing this bill, HB 429, which seeks to delegate inspection authority to counties? It's not only problem in Montgomery County, there is problem across the jurisdiction, including my county, Baltimore County. That may be better positioned to conduct timely nursing home inspections, and wouldn't decentralizing oversight help elevate the backlog and ensure more immediate response to potential issues in nursing home? This is serious issues.
So I think a little history might help elucidate this. So Montgomery County wasn't the only county with whom we had contracts. We had contracts with multiple counties in the past, in the 2010s. And the coordination required, the cost of that coordination, it was a burden. And we did see that numbers were starting to slip. I mean, when you look at the survey activity in long-term care survey activity in 2019, it was already going down. And so that was the main reason that we started pulling that back so that we can actually more efficiently do this. I'll note that, a large part of the problem here happened during the pandemic, of course, both between the pandemic and every single state was hit with this issue, right? So contracting this out would not have changed that one bit. And then there was the cybersecurity incident that happened that also, particularly for Maryland, was a hit on top of the COVID issue, and that put us back by about 5 to 6 months as well. Not insignificant when we're talking about annual surveys, right? And so there are some very serious issues that landed. Now, there were also some operational issues there, and we are cleaning those up as well, right? I don't want to attribute it just to that. So it's not from our perspective, it's still a state function. It still needs to remain a state function. It's not something that we can wash our hands of. We are still responsible for the oversight of it. The best analogy I can give you is that when we carry out these functions with CMS, we have these discussions, right? And we look at what other states are doing, and other states, to our knowledge, are not subcontracting this out to individual localities, right? But what they're saying is if we need more help, we'll get it at the statewide level. So they use contractors, which is what we're doing right now, in part to catch up with the backlog. We've hired additional staff, which I thank the legislature for putting that into our budget in FY25. And that's why we're making the progress that we're making.
If I may.
Quickly, yes.
Yeah. I mean, is there any compromise point? What is the solution?
We have been ready to engage in a conversation. If the county wants to invest dollars, our core concern is to take dollars out of OHCQ and give it to a county. That is the issue that compromises our ability to be able to operate most efficiently. But we are happy for a county to be able to invest their dollars. We have been very consistent about that point. And as soon as any county, including Montgomery County, wants to take us up on that, we're ready to go.
Thank you.
Thank you. Delegate Bagnell.
Thank you, Madam Chair, and thank you, Dr. Kalyanaraman. And I'm just trying to drill down because I think we're all a little confused about what the issue is.
Mm-hmm.
Is this a concern about compliance because ultimately this is still the state's responsibility, or is it operational because the state wants the authority to subcontract rather than delegating that authority to the counties?
Delegate, it's a combination of a number of things. So we are responsible for the state. And we cannot, at the federal level, we cannot give up that responsibility. That's not an option. The best we can, even in these discussions, I want to note that if we are putting on the table delegating federal authority, we still have to get approval from CMS, and I cannot promise you that at any point. That is CMS's purview. So that just needs to be on the table. And if CMS doesn't give that authority, then we're talking about state authority only. And that's, I'm going to be honest with you, that's a mess if we're going to fork federal and state oversight. That said, we're still responsible for any county that wants to augment this. We're still responsible for the quality standards. When I mentioned that, our data is more, needs to be reviewed by CMS, CMS reviews every single survey that we do, and they review it for quality. We would be required to make sure that anything we're passing up to CMS, that we are reviewing as well. And so that means we have to do oversight of those staff. And so it just puts us in a challenging position to start carving up the state this way for what is fundamentally a state function.
And if I can follow up?
Yes.
So just to further clarify, are you concerned about a compliance issue if we have an MOU with counties?
Yes.
Okay.
Amongst other things, yes.
Thank you, Madam Chair.
Okay. Delegate Hill.
Thank you, Madam Chair, and thank you, Dr. Kellerman. I know I'm like a 5-year-old, okay? I know you feel like you've explained this 5 times, but I'm going to ask it a little bit different. my understanding is that you have responsibility for doing the surveys, for reviewing the survey data, and reporting it to the feds.
Correct.
Right. And that for whatever reason, COVID or other reasons, surveys aren't getting done the way they should. So you have the choice of increasing staff within your budget to carry out statewide surveys, contracting with an outside vendor to carry out some or all of the statewide surveys, which you would then have to review for accuracy and all of that kind of stuff and then report. Or what this bill would suggest, contract some of it to the local jurisdictions and your outside contractors and whatever additional staff you're hiring so that all 24 jurisdictions would be covered in some mishmash of what is essentially all contracting, right? And still have the same in-house people who have to review it. They have to review it whether folks are staff, contracted staff, or county folks. So if it's the county, there's a contribution to the workforce. They're going to contribute some money. If it's a contractor, they're not contributing any money. And if it's all state employees, we'll stay behind for a long time because we can't catch up for some time because we've fallen so far behind. So is that, am I getting that right, or am I missing something between those three options?
Well, I think there's a little bit more to it than that. Okay. So we are catching up. We have decreased by almost 50% the number of outstanding complaints. We are at nearly 50% of annual surveys, which are within the stated timeframe, 16 months, right? And that trajectory is continuing. It's not like we're plateauing. I'm going to reiterate that we're happy for a county to invest. Our issue is with taking money out of OHCQ and giving it to another county. That's the issue.
I guess the problem is you're not giving it to the county, you're giving it to the people doing the inspection, and you're either going to give it to a third-party vendor for them to hire the contractors, or you're going to give it to the county for them to share hiring of the contractors, or you're going to hire people to do it directly. But that's not accurate either?
So we have
so the
already,
money's leaving you one way or the other.
Well, it's not leaving us when we hire staff. We have hired staff, right? So I think one nuance here is that when that money is given to the county, those surveys are only going to be done in Montgomery County, right? And we're not going to, those surveyors are only going to work in Montgomery County, and we're not going to have the flexibility. We now have a piece of our funds are locked into a county, and we do need to be able to be flexibly allocating staff across the state whenever we need to. There are moments where Montgomery County is going to get more surveys per month than another county, and there are less, right? That's just the cadence of survey activity. But once it gets locked into Montgomery County, we as the state have less flexibility, and Montgomery County is a big county. It's a sixth of the population, right? So that locks out a sixth of our staffing from the rest of the state.
I think I get it now. So there's a flexibility of moving these inspectors all around the state that you lack if it's only a county or two. But if it were 20 counties, you might gain some of that back. But it's the case by case where they're dedicated to one county, they can't be used somewhere else, and you've made that commitment, and you don't feel like prorating across based on the number of nursing homes that have to be covered per county, that you're not comfortable prorating how much you go to Montgomery County to do the work they have to do versus how much you go to Baltimore County to do the work that they have to do. It's that lack of flexibility that is a big sticking point.
It would start decreasing our flexibility.
All right, thank you.
So I don't see any other delegates, but I guess I have to ask, are we not out of compliance now?
Yes, we are.
Okay. And if you wouldn't be paying 100% of the cost of if there are 6 surveyors in Montgomery County, you would be essentially paying for 3, right? And Therefore, you would have 3 positions you wouldn't have to worry about Montgomery County. So you're not going to send the staff you've got to Montgomery County. So you're actually able to use those 3 positions that you're saving for the rest of the state. And I guess I also want to be clear, are you supposing that Montgomery County is seeking oversight and reporting to the state? Because I thought the bill was pretty clear that, and the previous MOU said, the results of all the surveys and complaints and resolutions of those complaints were all reported to the state.
So Delegate, we can't ever say that's Montgomery County's problem or issue or responsibility. The state always retains the responsibility. That can't be given away. What we can give away is partnership. Well, we can not give away, but what we can get assistance with is partnership in that. But we can't say we wash our hands of what happens in those within that boundary. That's not an option for us, which means that when we do something, when we propose something like this bill, it limits our ability. And I just want to note that we talk about this as if Montgomery County is absolutely going to be able to fully fill the positions and always operate at full efficiency. I do want to note that if that doesn't happen, the state will have to carry that load and will have fewer dollars to be able to do that.
Okay, I think, we just need to continue these conversations because I don't know that I'm getting to the core issue here. One word, Delegate.
Pilot?
We like those, don't we? Okay, seeing no one else with the light on, thank you very much. Thanks for your patience. I know you have been here all day. I appreciate you answering our questions. And we will certainly be having more conversations. And that concludes the hearing on House Bill 429. And we will move to the last bill of the day, which is sponsored by Delegate Kipke. And it is House Bill 418, Health Maintenance Organizations, Payments to Non-Participating Providers, Reimbursement Rate.
Let's get this show started.
He has one virtual, but just on his panel, so I can just, if he's here.
Good evening, ladies and gentlemen. Thank you, Madam Chairwoman. My name is Nick Kipke, and I am presenting House Bill 418. House Bill 418 would update the payment model for HMOs. It would force them to change the way they reimburse out-of-network physicians. HMO, it's a little complicated, but what it would exactly do is it would require reimbursement to out-of-network providers be 125% of the rate that they paid as of January 31st, 2019, adjusted for inflation, or the allowed amount for the service as of January 1st, 2025, adjusted for inflation, whichever is greater. Why is it necessary? Carriers benefit from lower hospital rates in Maryland, pay Maryland physicians lower rates than physicians in other states, and shift the burden of physician subsidies needed to maintain core hospital services to Maryland hospitals, which is unfair and unsustainable. You will recall we've heard a lot about that as those unregulated, we can't help with that with our all-payer system currently. Hospitals then subsidize hospital-based physicians to recruit them and retain these physicians who are essential for patient care. And a point that's very important that doesn't get brought up enough is just like everything else, we are in competition with the rest of the country as it relates to having enough providers in our state. And currently, we're at sort of a crisis. You keep hearing about it, I keep hearing about it, in staffing in our medical universe in the state of Maryland, and we are losing providers to other states. Requiring carriers to increase their reimbursement to participating physicians is one way to right the healthcare system and encourages fair negotiations between carriers and physicians and other folks, thereby decreasing the burden on hospitals to make up for low physician reimbursement. This issue is also not new. I wish the chair, Jocelyn Pena-Melnick, were here, because when we first came to the legislature, I believe in 2007, we had a similar bill that we passed that did the exact same thing for the PPO market. And so what we're not breaking any ground here. What we're seeking to do is to replicate that in the HMO market. With the question that I think will come up is, will costs and premiums go up if we increase this reimbursement? And the short answer is no. HMO claims are such a small percentage of total claims, 0.4%, that any increase in reimbursement rates for such claims would be immaterial to overall healthcare costs and premiums, but very important for the negotiations between the provider and the carrier. It gives them more leverage, and ultimately, as we saw in the PPO situation, many more providers got into network because they had a fair basis for which to negotiate. So don't be fooled by the argument that this was as it was the same argument used in the past, and it didn't bear to be true. Lastly, I will just mention there is an amendment that is in your packet that is a technical amendment. And with that, I conclude my testimony and ask for a favorable conclusion. Thank you.
Would you like to go next?
I'll go next. Good evening, Madam Vice Chair, members of the committee. My name is Dan Shattuck. I'm here today on behalf of the Maryland Society of Anesthesiologists. I wear a couple hats. I serve as their executive director. The Maryland Society of Anesthesiologists represents anesthesiologists all across the state, and I have been hearing from the members about the challenges they're having coming up with fair contracts with the insurance carriers. You'll hear a lot today and maybe over some other days about the challenges facing anesthesiology. There's a shortage of anesthesiologists. There's tremendous difficulty in recruiting and retaining, and Delegate Kipke made a great point that it's a national market for really all providers, and trying to get the hospital sufficiently staffed so that anesthesiologists are there to care for the patients is essential. Anesthesiologists treat patients and they don't have the opportunity to ask what their insurance status is. You come into the hospital, whether it's through the emergency department or other reasons, maybe labor and delivery, and you need an epidural or you need to have a C-section, the anesthesiologist is gonna be there, they're gonna treat you, and they're not gonna worry about the insurance until the end and when their billing department, digs in. So they don't get to choose, and they're happy to provide the care. So in the instance when a group might be out of network with an HMO, what this bill is going to do is provide a fair and transparent payment for that out-of-network service. It's not the design of HMOs to have out-of-network care, but in the case, again, of hospital-based physicians in particular, there are instances where an HMO patient's going to see an out-of-network provider. This bill mirrors what's in the PPO law. It's going to provide, again, that transparent level. It's not breaking new ground. We think it's an important step to take. The technical amendment creates a greater of scenario to make sure that providers aren't going to get less than what they're getting today. And if I could just add one more quick point, I know you've seen the Healthcare Commission study that the HGO Committee directed them to do. I've got to just say that there was little to no provider input. The study doesn't include anesthesia. There was complications with data. We were never contacted, even though we had reached out to the Healthcare Commission a number of times to, be a part of the study. So there's a lot of gaps in what was presented. There's a lot of incomplete data. So I'm just saying we're happy to talk more about the study and some of the numbers that are shown in there. But with that, thank you for your attention, and I urge a favorable report.
Good evening, Madam Chair and committee. For the record, my name is Dr. Reginald Brown. I'm a board-certified emergency physician. On behalf of the Maryland chapter of the American College of Emergency Physicians, we lend our strongest support to House Bill 418. This bill is modeled after its predecessor in the PPO market that successfully brought providers and insurance carriers together. The bill levels the playing field across all the markets. We are aligned with our insurance providers in stating that in-network coverage is optimal for our patients. The PPO legislation has a proven record of bringing us together. If one thing is clear from the MHCC report, it is that current HMO model does not foster in-network partnership. In 2024, the written opposition from Kaiser Permanente boldly stated, and I quote, "They are selective about which health providers it contracts with in order to provide the highest quality, affordable health coverage for its members." The question begs, which emergency groups or which emergency providers in Maryland are they contracted with? What is the example of the highest quality, affordable care in Maryland? Is it all emergency providers? Is it half of us? Is it none of us? Emergency providers and our nursing colleagues care for all patients that come through our doors. We are the safety net for pandemics, mass casualties, and those inadequately insured, whether or not their insurance companies are negotiating fairly. We are not selective. We provide high-quality care for all. The opposition will also likely cite the MHCC study in their remarks. We have some questions about the study. Chiefly, why is data from Kaiser representing, according to their testimony last year, nearly 500,000 Marylanders not included? The entire committee is aware of ED wait time crisis. Your constituents are demanding change. Which wait time committees do the carriers here in opposition today participate, offering insights or capital towards their quality claims? I'll close with, since June, I've had the privilege of serving as assistant director for 10 emergency departments in Maryland, from Bel Air to Easton, Laurel, Bowie, Largo, from Chestertown to Charles River. My chief priority is recruiting and retaining top emergency medicine talent in Maryland. House Bill 418 is critical to that mission. I implore you to return a favorable report in support of high-quality emergency care in Maryland. Thank you.
Madam Chair, members of the committee, Barbara Brocato, and here tonight in support of House Bill 418, and a previous witness said a sense of urgency with a true sense of urgency. I'm here for the Maryland Psychological Association, the American Physical Therapy Association, Maryland Dermatological Association, Maryland Academy of Nutritionists and Dietitians. You know, I've been in this a long time, some of you have, and I have to say that the insurers in their testimony talked about there being $30,000 shortage of providers, mental health providers. And we can tell you, mental health providers are leaving networks because they can't make a living. They can't sustain it. They are leaving the profession, and physical therapy practices are closing. They haven't gotten an increase in their contractual rate for 10 years. The insurers' arguments 10 years ago was that if we pass that bill, there was not going to be a hospital-based physician in their networks. The opposite happened. I really ask you to take a strong look at the situation here with the shortage of providers and ask you to give this a favorable report. And we're glad to work with you, the insurers, everyone. But the time has come and this needs to happen. Thank you.
Vice Chair Collison, members of the committee, once again, Dana Kaufman. On behalf of MedChi, we are in support of the bill. We are in support of the bill with the amendment. The amendment looks to hold harmless some societies that had a concern that their rates could be lower, but there is a bigger issue that we're talking about here. And you've heard me say it. I'm going to say it every time I get a chance to, all the way to the end of session. Maryland's physician payment rates are some of the lowest in the country. We have the top medical systems here in this state, and we have the lowest patient reimbursement rates, and that is a problem, and that has to be addressed, and that is why we have, when you can leave a network, sometimes you can't leave a network because, frankly, too many of your patients are within that health plan. But that has to be addressed because we can't, the physicians, as said before, it's non-sustainable. And you're seeing now your constituents are getting letters basically saying that we're sorry, but our practice is leaving this health plan or this network because the payment rates are too low. And that's why we have non-participating provider rates. Now, you can also hear that if you pass this bill or if you make changes, then there is an issue with not incentivizing, that providers won't be incentivized to join networks. But the incentive will be there if the payment rate is fair. And that's the big issue too. In one of the comments that was made in the Maryland Healthcare Commission report, and I said this the other day, is the number of provider terminations that are occurring. There was about 15,000, or hold on, it's 15,627 network contracts were terminated across specialties. 14,910 were terminated by providers. We need to find out why, and I can guarantee you it's because payment rates are too low. So we need a solution, whether, some solution, and we need to work with you on it. So thank you very much.
We do have a virtual witness, Dr. Brown.
Go ahead, Doc.
Okay, sorry. I couldn't hear what was being said. Madam Chairman, members of the committee, I'm sorry I couldn't be down in Annapolis. Delegate Kipke, thanks for your help. I'm here to testify in support of House Bill 418 with the amendments mentioned. I'm the current president of the Maryland Society of Anesthesiologists. My name is Ram Paravemba. And over the last few years, we've had to deal with an extreme shortage of anesthesiologists in Maryland. As a result, and I think one thing to clearly remember is that when we have a shortage of physicians, really it's an access to care issue. It's a health disparities issue. It's a health equity issue, as those most vulnerable populations may have even greater access to care issues as are greater access to care issues than areas that are more well-populated or have more physicians. This has hit us hard over the last few years, and as far as the ability to recruit anesthesiologists in Maryland, and we actually came to the point that we wanted to, we developed a report last year sponsored by the MSA that showed that the real reason is a growing or an increasing demand for surgical services and a lower reimbursement rate in Maryland for anesthesiologists were the major causes of this decreased ability to recruit. We think, and we do believe, and we know that HB 418 will be critical and one step towards correcting that, as low reimbursement rates are one of the factors that are contributing to this inability to recruit. I will lastly say, and I know I'm running short on time, but I was one of the few physicians, and probably the only one, I guess, in this hearing, that was there during the PPO bill, the Assignment of Benefits bill, and was integral in developing language in developing that bill at that time. And a specific study was carried out in 2015 to show the impacts. And many will argue that this bill will do the same thing, that physicians will drop out of network, it'll increase costs. That study clearly delineated that that's not the case. More physicians were in network. The burden for patients was much less with regard to out-of-network payments and so forth. So I ask for a favorable response on this bill. I believe the results will be the same. More physicians will be in network, more patients will get care. There will be increased physicians coming to Maryland to practice with higher reimbursement rates. This is one step. We have other steps that are also necessary to get to that point, but I think it's critical that that a favorable result occur for this bill this year. Thank you.
Thank you. And thank you all. And so time for questions. I saw Delegate Hutchinson first, and then we'll go to the left side.
Thank you, Madam Chair. And I guess to the delegate, and you can decide who wants to answer it. My experience has always been, thinking that patient care is better when physicians are in network. But that's not really the question overall, is what have the providers been experiencing in their contractual negotiations with the carriers?
So I'm employed by USACS. We're a national emergency medicine group, and we always, as a general practice, remained in network across the board, both in Maryland and nationally. After the No Surprises Act was passed, we were forced out of network in some of the HMO markets. We certainly still harbor great partnerships with others in the PPO market and maintain a general practice to remain in network across 90% of our contracts in this state and beyond.
Thank you.
Okay. We're going to go with Delegate Szeliga.
Thank you, Madam Vice Chair. Thank you all for being here. I think it is, the two complaints I hear the most is about the patients who are having trouble locating a physician and physicians who are, having trouble recruiting the next generation of physicians to come here. So I think we obviously need to do something. Was the positive effect of the PPO law emphasized in the recent Maryland Healthcare Commission report that was to investigate the impact of similar methodologies as proposed in last year's HMO bill? What can you tell us about that?
Oh, yes. Disappointingly, I think, the hope was, and I thought that the intent was that we look at what happened in the PPO market and how as it was mentioned, how the rate of participation went, in-network participation from before the law passed for hospital-based physicians. I think the out-of-network rate was about 35%. There was a sunset because there was so much opposition. 5 years later, it had gone down to 17%. 5 years later, it had gone down to 3.6% out-of-network. We really had hoped that we would look at the success of the PPO law and that it brought the payers and providers to the table in a way that was constructive. We all here know that sometimes we pass a law with an intent, and the intent is not always exactly, it doesn't come out exactly how we wanted. There was a bill, here's a law in this complex healthcare system that worked. And that's why we say in the HMO market, that the HMO market has got to be suffering these shortages. And it's not just the physicians. You'll hear, I think, from Dr. Savage, a psychologist we have, and a physical therapist here waiting to testify with you about practices, and people that have been trying for 10 years to negotiate a better contractual rate, and they're about ready to close their doors. So I hope that answers your question.
Thank you.
Okay. Delegate Morgan. It's Chisholm.
Chisholm.
Delegate Chisholm, sorry.
I know. Same opinion most of the time. Thank you, Madam Chair. This is the first time I've seen Deborah and Barbara Picado against each other in a bill. And first of all, I don't know how that happens. But anyway, I do want to give Delegate Kipke an opportunity to at least address, there's a letter in here from the Maryland Right to Life, and I can't make a connection on how how it even relates to this bill, but did you read it, and do you want to make any comments on their opposition?
Yeah, respectfully, I read it, and I can't find the connection either, and I plan to ask them on the phone at some point. But I don't think that this bill in any way should cause them concern.
Thank you. I know it's an important issue too, so I wanted to give you the opportunity to answer. Thank you, Madam Chair.
Thank you. Delegate Bandari.
Thank you, Madam Chair. Vice Chair, by establishing a baseline year, like for example, January 31st, 2019, and establishing a greater of designation for reimbursement rates, how will this help protect providers from carriers reducing contractual rates year by year?
Thank you for that question, Delegate. I think what it does is it creates a definite point in time where they look back to that time, and then with the escalation or an escalator to, advance that base rate each year, it prevents a scenario from happening that we've heard of and seen in other areas where, because the contractual rate is what you agree to be a network, if that contract is terminated or if there's an effort to reduce that contractual rate, that contractual rate year over year could be reduced. And that number becomes important after the passage of the No Surprises Act, which looks at median contractual rate as part of the computation for the QPA. So insurers can, in the markets where they're able to, can take advantage of that prior year reference and bring it down. So the prior year is always changing. The prior value is always changing. So by having that date certain with the escalator, it kind of prevents that pattern from happening. And that's proven successful in the PPO where there is the date certain with an escalator. So.
Thank you.
Okay. Delegate Gazzoni.
Thank you, Madam Vice Chair. I almost pushed the button. Could you talk a little bit more about how USACS kind of works and how it operates? My understanding from some folks is that essentially it's that you're contracting all the ED doctors and that there may be some private equity behind the initial start of that. So could you just sort of tell me how that works?
Yes, thank you for the question, Delegate Gazzone. So yeah, there is a bit of a misconception that U.S. Acute Care Solutions is fully backed by private equity. We, in their acquisition of Alteon, another emergency medicine group in 2023, bought out all of their private equity interest. We do have a loan, which we pay back at terms, which allows us to have the capital to come and acquire 10 emergency medicine or 10 facilities as we did in June of 2024 to staff those sites and provide the background of a national entity for quality care, for support of the providers and best-in-class benefits. So here in the DMV area, including Maryland, we see close to 4 million patients over about 50 different sites, and nationally we're at 11 million patients at 500 sites.
Thank you.
Thank you.
Okay. Seeing no other questions, thank you all very much. Thank you for the bill, Delegate. And I will call an unfavorable panel. Rory Murray, Bruce Woolham, Matt Celentano, Kimberly Robinson.
Where do you want to go?
Yeah.
Madam Chair, members of the HGO Committee, once again, Matt Celentano today here on behalf of the League of Life and Health Insurers of Maryland in opposition to House Bill 418. This legislation will do nothing except raise costs for consumers with zero benefits to them. It will not improve care. It won't streamline coordination. It purely picks winners and losers in how they are reimbursed by HMOs. The irony of this discussion is that this bill was offered by the ER docs, but in the interim, the MHCC took a look at it, and they actually fare worse under this proposal than they would have before the bill was introduced. The whole point of an HMO product is that a consumer accepts a narrower network with the same rich benefit structure you get in a PPO product. This legislation threatens that choice. The MHCC work also supports this. The HMO products, by design to create affordability, have narrower networks. As all of you know, on this committee, the No Surprises Act in Congress was passed to prevent providers from balance billing consumers for services provided in out-of-network situations. This bill wants to reverse engineer that consumer protection law by indexing the reimbursement rates in 2019, just prior to the No Surprises Act. We think it's an end around on a significant piece of legislation from Congress to protect unknowing patients, and the impact of this legislation will result in higher bills for consumers, increased premiums, as well as disincentivizing provider groups to join HMO networks. We also, if you'll notice in the MHCC slide deck that came in the commission meeting in December, they said they still owed you a report. We have not seen that report as of yet. For all these reasons, we urge an unfavorable report on House Bill 418.
Thank you. Yeah, you want to go ahead? Good afternoon or good evening, Madam Chair, members of the committee. Kimberly Robinson on behalf of Care First Blue Cross Blue Shield in respectful opposition to the legislation to House Bill 418. I think Mr. Celentano did a good job distinguishing sort of where we are in time, both with regard to the No Surprises Act, but I want to talk a little bit about why there are two different formulas in Maryland law. HMOs and PPOs are two very different products in terms of how they provide the benefits to the members, and as Mr. Celentano mentioned, how those networks are developed. HMOs do have a very limited out-of-network benefit. That is a characteristic of that product. It does in fact impact the rating or the premiums rather, for how those products are developed. And the PPO law, which came sometime after the HMO law, intentionally didn't just mirror the HMO law, because part of that was in recognition that those are two different products with two different financial structures. With all due respect to Delegate Kipke on the question of whether or not forcing up provider reimbursement would have an impact on premium, I would argue, in fact, the answer is yes. It is not a matter of how many claims in the healthcare ecosystem come from HMOs. HMO rates are based exclusively on the claims under that HMO product. So if the costs inside of that product go up, the premium inside of that product goes up. The timing for when this proposal has been pegged, it is interesting that it happens to be the year right before No Surprises, which came about because of extreme balance billing in hospital-based settings, became the law of the land at the federal level to address the balance billing that patients in HMO products and others were suffering in other states. Maryland created that formula to protect Marylanders from those sorts of experiences, right? That was part of how the HMO formula first came to be because of the nature of that product, and the PPO law, for similar reasons, came to be and took a different path. We are happy to continue to have conversations about the bill, but as introduced, we urge an unfavorable report. Thank you. Rory?
I'm Rory Murray on behalf of Kaiser Permanente. I'm the last thing standing between you and dinner, so I apologize. Listen, everybody said everything that needed to be said. I'll just hammer home. The MHCC did a study, and the study showed that the average overall across all payers, all healthcare settings, would be a net loss. There's some winners, the panel behind me, but everybody else, including critical care physicians, who would see across all payers, across all settings, a 75% drop in reimbursements. It didn't turn out well. So what do? You come up here and you attack the study. But the MHCC did what was requested by this committee, and the numbers are what they are. I'd be more than happy to talk about, because it was brought up by the previous panel, why Kaiser Permanente doesn't currently have an in-network. I'm blinking here with U.S. Acute Care Solutions. However, I know it's late in the day. I'm short on time. If anybody wants to talk to me offline about it, happy to do that. Or if you want me to say it here, I'm happy to do that as well. So, but the point has been made.
Thank you. Questions? Delegate Hill?
Thank you.
Each of you spoke about why HMO systems were set up the way they were, and the contract between the carrier and the patient, the subscriber, and those reimbursement rates. This bill is not about that. This bill is about the out-of-network person, the out-of-network person who gets called in to a hospital to see a patient because the HMO does not provide people to cover services in that hospital. It is about the provider who provides services after hours because the HMO has, limited providers who aren't available 24/7. They're available for the working hours or not. It's about the people who are filling in the blanks. And what you're suggesting, if I'm hearing you correctly, is that the fact that they're not in the network doesn't mean that the HMO shouldn't be dictating what they get paid, and that they should be penalized for not being in the network by having the value and the charges for their services limited by someone that they chose not to contract with or could not have been allowed to contract with because of the limited thing. So you're penalizing them, and they had nothing to do with it. I think, so where am I wrong about that?
So I'm trying to follow the way you described that, Delegate Hill. So you've got two very different models of HMO sitting at the table, right? So you've got one who employs providers. You talked about it as though the providers were, quote unquote, working for the HMO. And I'm not sure if that's just language you chose or if you were thinking about a model.
I'm talking about in-network providers have a contract with the HMO.
Mm-hmm.
By definition, they're getting paid based on something that they negotiated.
Mm-hmm.
Out-of-network providers do not have a contract.
Mm-hmm.
They're being called to take care of patients because the in-network provider is not available. What this bill is trying to do, as I understand it, is say that that out-of-network provider, although we're going to limit their reimbursement somewhat, they should not be limited in a way that has to pay some respect to a contract between a patient and an HMO that they are not they're not under the contract.
So the setting in which that happens is going to be a hospital-based setting, right? Because
Not
HMO
always.
contracts generally do not provide out-of-network benefits. That's the difference between it being in an HMO product and a PPO product. Preferred provider organization means that there are providers who are preferred, but you have an out-of-network benefit that comes with that, right? So HMO products are very often what we call closed panel products where you have to see in-network providers. That works a certain way when the patient has the opportunity to go into the directory to find that provider to get the appointment. We have a whole exceptions process when there are not enough providers in a particular specialty. But in general, that's the design, right? The place you're most likely to encounter an out-of-network provider is going to be in the emergency space. Because I think as someone mentioned on the other, well, actually, I'll take that back. It was in last year's hearing because I just watched it. Last year, one of my colleagues had talked about the fact that we all understand that is a moment in which you are not picking. When you have an emergency, you're going to the closest emergency room without regard to whether or not that ER provider has chosen to be in the network or not. We need you to get to that emergency care. And as a result of that, Maryland took it upon itself many, many years ago to create a formula that addressed how those out-of-network services were reimbursed, written by this General Assembly. Behind that, you had the experience where, because those were truly out-of-network services not covered traditionally by your plan, there was the opportunity for balance billing. The types of providers who most often balance billed, and this is not me making it up, it's why the No Surprises Act exists, happen to be hospital-based providers, specifically radiologists, anesthesiologists, and ER specialists, and ER providers, right? And so that created a formula at the federal level for how that was going to be managed and what the expectation was for how HMOs reimburse those individuals. The ask before you today is to take the formula that Maryland created to make sure that patients were being protected from those balance bills and created that reimbursement schedule outside of those in-network services and change it. Create a new reference date, create a new calculation for how that happens. We have differing opinions about what the impact of that change in calculation is going to be. But at the end of the day, it doesn't change the actual experience of the patient, because in either scenario, the patient is the one who is effectively being held harmless under the law.
Right.
You're right. The question is about what is the experience of the provider, not necessarily the impact to the individual.
Correct. And so what you said, and I appreciate, that was a wonderful summary. Thank you. Well done. That's why I always like talking with you, because I always get history when I talk to you, is that a formula was written And this bill suggests the formula needs to be revised. It's as simple as that.
It is. We just disagree about whether or not it should be and how it should be. I think one of the things that I'm not sure since this bill was first introduced that there's been a real conversation about is it, even if it should be revised, is this the right formula, right? I don't know that there's been any real analysis of what makes sense as a formula. This is just the formula the proponents chose. And so I think that's a different discussion that hasn't necessarily occurred.
Just one, yeah. So, I mean, I will say that reading the bill, other than seeing the study, I was actually shocked that somehow there's concern there's going to be too much paid by indexing it to 2019 and then the years between versus the year before. And the only reason that a provider out of network will be getting more under this proposed formula than they are before is if we're seeing that people in the HMO who are contracted have study rates that don't go up every year. So you're actually locked into the year before rate is the same as 2 years before, is the same as 3 years before, even though your cost and expenses and cost of living go up. So you're tied to this contract. Or if, as was suggested in the previous panel, that in fact, because of their ability to contract with in-network providers, they actually have the ability to lower reimbursements over time. So I guess my point is that, to your point, is this the right formula? It is shocking to me that there's so much concern that this new formula is going to pay more, because to look at it, you'd think the old formula would have worked very well, but it apparently hasn't.
I think the MHCC report reflects that it depends on what specialty you're in, how the formula is going to affect you, and that differs by provider. I also think, I think we've had a lot of bills just in the last 2 days that talked about reimbursement. Most states don't do what Maryland does, which is decide as a legislature how to reimburse providers. I think it's interesting that as the state who sets those rates, we also are the state who keeps saying that we're paying providers less, compared to states where nobody is interfering in how providers and carriers are negotiating their own rates. I don't know what the correlation is between those things. I think there's a different conversation we might need to have about provider reimbursement in our state.
Well met.
Delegate Bagno.
Thank you, Madam Chair. And Mr. Rory, Mr. Rory, it's late. Mr. Murray, I'm going to direct this at you because Kaiser Permanente is an integrated system. We're hearing that our provider rates are flat 5 years, 8 years, even 10 years out, but our premium rates are increasing. So what percentage of the premium collected is allocated to direct patient care through the payment of providers?
I would have to run that through the chain. If you haven't noticed, I'm not Allison Taylor. I do not have nearly the knowledge she has. I'm still learning a lot of it, but I'll take that question back to her and get you a number.
And can you share it with the entire
Yes.
committee? All right, thank you.
Okay. Delegate Hutchinson.
Thank you, Madam Chair. Questions for Kim. So can an insurance company unilaterally change a contract mid-year, including payment rates?
I am not on the, I'm not on the contracting team. So I don't just independently know that answer. I will also ask that question. My gut says no. That's not typically how contracts work, just in the world, and I would not expect that we're doing that with our providers. There's certainly going to be provisions. Maryland law has a lot of provisions around how and when contracts can be changed. And even when the carrier can decide to change them, there's significant notice and things like that that have to be given. But I will ask that more specific question.
Thank you.
Mm-hmm.
Any further questions? Seeing none, thank you all very much for your time and your testimony and waiting around today. We do have two virtual, and they're stalwart. So if you'd bring them up, these are two favorable witnesses. And we'll go with Dr. Savage first, since we see him first.
Your testimony and waiting around today. We do have two virtual.
You'll need to turn off your.
So if you bring them up, these are two favorable witnesses.
What does he have to turn off?
And we'll go with Dr. Savage first, since we see him first. Your testimony and waiting around today.
What is it?
We do have two virtual.
Okay. Dr. Savage, can you turn off your YouTube feed, please?
These are two favorable witnesses. They have, what does he have to turn on?
Otherwise I keep hearing myself.
We'll go with Dr. Savage first.
No.
He's seen first. Testimony and waiting around today.
Okay.
Let's do it to virtual.
We're gonna go.
Okay. Dr. Savage, can you turn off your YouTube feed, please? These are two favorable witnesses. They have, what does he have to turn on?
Talk about a loop. Okay. Okay, now, Dr. Savage, you're muted. So just take yourself off mute. Can you do that?
Feed, please.
Okay. Okay. All right. Okay, if you just turn off YouTube, Dr. Savage, that's all. And then unmute yourself.
Does that work?
There we go. Now we're on. All right. Okay, you can go ahead, Dr. Savage.
So we're good?
We're good.
Okay, thank
Okay,
you.
if you just turn off YouTube, Dr. Savage, that's all.
Got it.
There you go. Okay.
Sorry about that. The Honorable Vice Chair Cullison and members of the HGO Committee, good evening. Thank you for the opportunity to address you today. It is good to see you in the committee again. I am Dr. Pat Savage, a retired licensed psychologist in Maryland, and I am testifying in strong support of HB 418 on behalf of the more than 1,000 members of the Maryland Psychological Association. We support this bill for 4 reasons. 1, it simplifies and clarifies the administrative aspects of providing mental health care. Providing mental health care has always been a challenging endeavor. Over my 38 years of practice, providing care became increasingly more complex and burdened by administrative regulations that did little to enhance the quality of care. Anything that can be done to simplify the administrative burden on practitioners is welcome. 2, it provides increased access to care by encouraging out-of-network providers to offer their services to HMO members by increasing the fees they are paid by at least the rate of inflation. It is well known that mental health care is inadequately reimbursed by insurers, which has led to a dearth of providers willing to care for HMO members. HMO reimbursement rates have traditionally been far below the usual and customary rates charged by many providers and have not been indexed to reflect inflation. Mid-career, I withdrew from providing care through HMOs for the simple reason that already low reimbursement rates were not keeping up with the rate of inflation, making sustaining a practice unfeasible. My withdrawal also fortunately allowed me to selectively provide pro bono or low-cost services to members of my community. Item 3, it protects patients and providers by providing a clear formula to determine out-of-network payments that is not confusing and that has been shown to eliminate surprise billing, hence avoiding patient-provider conflicts that can diminish the effectiveness of mental health care. Number 4, it allows patients in need of specialized services to more easily obtain them when they are not available through HMO because more providers
Go ahead and
are willing to
go ahead and
participate.
finish your thought.
For these reasons, I ask a favorable report on 418. Thank you, Delegate Kipke, for submitting the bill. And I'd like to just add an apology to Delegate Woods on HB 665. Had I known that that bill was going to be heard before this one, I would have provided oral testimony as well in support. We did provide written. So thank you for this opportunity to speak to you today.
Thank you. Are there questions of this witness? Seeing none, thank you very much. And for our last witness of the day, Linda Horn.
Hello. Chairman and delegates, my name is Linda Horn. I'm a licensed physical therapist in the state of Maryland and the State Government Relations Chairperson for the American Physical Therapy Association, Maryland. I'm here today representing the American Physical Therapy Association in support of House Bill 418. I've been a physical therapist in Maryland for over 40 years. In that time, less people who need physical therapy have been able to access it due to costly copays and coinsurance, lack of physical therapy practices near their homes, and lack of transportation to get to those physical therapy practices outside their communities. Maryland outpatient and private physical therapy practices are increasingly unable to maintain their practice and staff and stay in contract with carriers because they're not being paid fairly. Maryland is already among the states with the lowest reimbursement rate to providers. And as insurers continue to decrease payments to providers, premiums have gone up annually, all the while practices have not had their rate increased in 10 to 20 years. The lack of inflation-based updates to contract fees and rising practice costs due to inflation continue to widen the gap. This increasing discrepancy between what it costs to run a practice and actual payment, combined with the administrative and financial burden of participating in state and federal insurance plans, are contributing to provider burnout, contributing to decreased patient access to care, and is unsustainable. This in turn limits a patient's ability to access services when healthcare practices change to cash-based. HGO 418 would force insurers to pay better contractual rates and thus set the precedent for fair payment practices in the state. Physical therapists want to be a network and provide care for all patients in their location and are finding they can't do this. We went into this profession of physical therapy to help people to move better, have less pain, and have a better quality of life, and it's discouraging when we're unable to do so. For these reasons, I respectfully request the committee to support House Bill 418. Thank you for your consideration.
Thank you. Are there questions for this witness? You must have done a great job because there are no questions. Thank you very much, Dr. Horn.
Thank you.
And with that, that concludes the hearing on House Bills 418 and the work before us today. Thank you all for your time and endurance today. If you can take us down, this meeting is adjourned and committee